And Jamie, do you want to start?
Yep, hi everyone. I'm Jamie Wyke. I'm Director of Partnerships and Deputy Place Director for the Integrated Care Board, based here in Barnsley.
Peter McDonald, Chair Barnsley Hospital.
Hi, Booker, and Managing Director of Barnsley Hospital.
Hi, my name's Dawn. I'm Director of Strategy and Change at Swift.
Joanna Kay, Cabinet Spokesperson for Communities and Public Health, and I'm subbing for the lady today.
Paige Crowd, Risk and Governance Lead, South Yorkshire, and I'm covering for Alison Haig today.
Jill Stansfield, Director of Services in Community in Swift.
Leslie DeBell, an ICB non-executive member.
In Castley, I'm the BSARC CEO.
Ms. Bezowski, I'm Chair of Barnsley CBS.
Jenkins, Chief Executive, Barnsley Hospital.
Joe Markey, I'm just doing some work experience.
We're very happy to have you.
Roxanna Naylor, Director of Financial Transformation.
Angela Musgrave, Business Support Officer for Barnsley Place.
And Leah White, a Business Support Officer for Barnsley Place.
And Wendy Lauder, I'm the Exec Place Director for Barnsley, and colleagues on the screen, Joe.
Good afternoon, everyone. Jo Harrison, Deputy Chief Nurse for NHS South Yorkshire ICB Barnsley Place. I'm standing in today for our Director of Nursing, Alan Windlow, who gives his apologies.
Thank you, Mirban.
Mirban Ghani, GP and Chair of Barnsley Healthcare Federation. Good afternoon, all.
Good afternoon, Sarah.
Good afternoon, Sarah McGilvery, Director of Governance and Quality, Deputy Chief Exec, Barnsley Hospice. I'm here on behalf of Martin June.
Thanks, everyone. So we are not expecting any fire alarms, but I've got a feeling this building's winding down in of itself. Things are falling off or whatever. I don't know what's happening, but we're not expecting any fire alarms. And anybody that knows the building, most of us do know the building well now, don't you? So we know where to use the facilities. And please do help yourself to tea and coffee throughout the meeting as you need to. Please don't wait for a break. Apologies for absence.
We've got Carly Speechley, Council Houghton, Marie Burnham, Anna Hartley, Richard Lynch, Sarah Norman, James Barker, Madway Gunter-Muckler, Emma Bradshaw, Alan Windle, and Martin June.
Thank you very much. In terms of quoracy, we are quorate. Yes, thank you. Any declarations of interest relevant to the agenda at all today?
Yes, please, can I add one to mine? Which so my daughter works at Dale Barnsley.
Yeah. Yes, please forgive us if any strange noise is happening. So welcome to Lynn. Lynn very kindly joined us today to talk to us a bit more about research, and I'll hand over to you.
Okay, thank you. So I'm here today just to give a presentation on Barnsley Sexual Abuse and Rape Crisis Services, commonly known as BSARCs. I'm just going to give a case study. Jamie asked if I'd bring a case study, which I've done. I'm also going to give some basic statistics about what the work is, and then I'm going to talk about the national pilot project that's been run from Barnsley called Ask the Question. So the World Health Organization. It's very distant. The World Health Organization states that people who experience sexual harm are 8 times more likely to experience mental ill health, 6 times more likely to attempt suicide, and are 8 times more likely to continue to attempt suicide. The latest research done by the Centre for Expertise in Childhood Sexual Abuse says for boys, that's 13 times more likely, and that's the research carried out last year. We know that clients are more likely, 18 times more likely to misuse substances and 19 times more likely to misuse alcohol. They're also 17 times more likely to need probation services and are 4 times more likely to be victims of domestic abuse or perpetrators of domestic abuse. So we know that the impact of sexual harm is huge. We know that it's hiding, our client group are hiding in many of the services. They're coming round and round and round the same services. And just to look at it in pure monetary terms, they're using a lot of our country's resources. Thanks. So just to give a case study that illustrates, this is a real client, the story's true. And I've got the client's express signed permission to be able to use anything in the information that she's given me, and that's what I'm doing. This is Josie's story. So Josie was around 7.5 when her parents left her with an older cousin. For people of my sort of age, you'll know that that saved you sitting in the working men's club with a bottle of warm lemonade and a paper straw. So she was looked after, and as far as her parents were concerned, was doing lots of nice activities. The sexual abuse started on that first day. The assaults continued for some long period, culminating in rape, continually over a period of years, and some really seriously heinous things were done to her, which I won't go into any detail on. At that early age, Josie was told that her parents would die if she told anybody. And as her gran had just died, she believed that. So like all victims of sexual harm, she was silenced by the perpetrator. That's how it continues, and that's how it continues to be successful. Later in her teenage years, she was told that no one would believe her, she'd be put into care, and then lots of derogatory terms that used against women were told that that's what Josie was by the perpetrator. She continued, she's a strong woman. She held a professional, well-paying job. She got her own house, and she held this down for some long time before she started with depression, anxiety, misusing alcohol, and taking. She was going around varying GPs, trying to get different medication, and her records, her letter from a psychiatrist very clearly says she was manipulating people to get enough medication to be able to attempt suicide. She was diagnosed with borderline personality disorder. It's a common diagnosis for a lot of our clients, which I find interesting. And she was put in a hefty medication and offered support of the community mental health team. She continued to misuse alcohol, started self-harming, started with attempted suicides, and she was admitted to psychiatric hospital in 2008. After a couple of years, continuing in and out, trying to continue to take her own life, her psychiatrist requested that she be taken to hospital in London, where she was for 6 years. She was on 4 very hefty doses of different mental health medication, and for all of those were for psychiatric issues. Even in hospital, her diaries clearly show, and her records clearly show, professional records, that she was, again, hiding medication, she was hiding blades, and continuing to attempt suicide. Self-harm was really noticeable. It's really visible on her. And on one of her cuts, she needed 28 stitches just to kind of deal with the pain that's inside her. She continued to attempt suicide. Eventually, she saw somebody who committed suicide in front of her in a really horrible, graphic way, and she decided that she would try to live. So she was released from hospital in 2016, still on 2 hefty doses of medication, and was given daily home support from the mental health team locally. After a period of her still self-harming and the mental health team feeling that she needed other support, she was referred to BSARCs in 2019, where we had her for 2 years. I have to say we would not be able to do that anymore. BSAC's on a deficit budget and our waiting list is vast, but at that period we could do that. We kept her for 2 years, where she had counselling, EMDR therapy, and throughout that entire period I was carrying the risk of that because she was still seriously self-harming. We obviously don't have the statutory responsibility for that. It was successful. We were up and down with her. We had constant contact with the mental health teams. And she still has 1 dose of medication, which is much lighter. She still has minimal support from the mental health care team in her own home. She's now a productive volunteer in the community. And for the past 3 years, not for the past 3 years though, she's no longer self-harmed and she doesn't have any suicidal ideation. And she says without BSAC she'd be dead. Her psychiatrist very clearly supports her thoughts on that she would be dead. So it's all about, for Josie, that's a great success. In so much as she's now out, she's living her life, she's no longer self-harming. Sometimes she'll call, she's still in touch with us. She calls to say she can't make the volunteering she was going to do because she's going out with friends. People are starting to know she's got a life. But what a waste of where she could have been due to a crime that was committed against her. And when I sent this, even though I knew the presentation had been agreed by Josie, I then rang Leanne going, can I just alter it a little bit? Can I take some bits out? And Leanne did that for me and made sure that this presentation came in. And I had to have a word with myself thinking, why have you done that? Because if this was a victim of a hit and run and this person had no legs, they would come in here and we'd be okay with it. Why am I thinking I need to give a trigger warning? Why am I thinking that what I've said is too hard hitting? And I think I'm looking at everybody around the table going, that's because we still keep this crime silent. Because somewhere between us, we are creating that atmosphere and we are making it that that person still carries the shame and guilt. And part of the Ask the Question project I'm coming on to is about saying to us, all of us, is can we stop that now? Can we now take that step forward? So even though in my role, I still did that, and Leanne will tell you, I rang her up going, oh, I can't breathe, what have I said? Okay, so if I go into so that is a success story. We've got loads of success stories, absolutely heaps of them. We've also got some where clients didn't reach us. So everyone will remember, I'm sure, the 13-year-old girl who took her own life. It was in the Chronicle. It's very well known that her parents firmly believe it's because she didn't get a referral to us, and so do we. We believe if we had that child, she'd still be alive. So for us, the impact is that much. So what do we offer? What is this stuff that we give? We have independent sexual violence advocacy as part of the South Yorkshire Sexual Violence Partnership. That project works with anyone who's reported to the police and are going through the justice process. Currently, that takes around 3.5 years to get to trial if there is going to be one. The CPS are taking longer to make decisions. Trials are being adjourned all the time. So that is slowing people exiting the service, which means we have to slow people coming in. This is where some of the backlog is. We have what we call externally wellbeing advocacy, what we call internally trauma resilience advocacy. And it's about people who are vulnerable, have chaotic lives, maybe low-level substance misusers, probably still too mentally ill to absorb deep-level therapy. Maybe work just in the gig economy. This is Barnsley. We have a lot of that where people need to go last minute or they can't eat that week to work, so they can't attend regular counselling. Putting that service in has meant that the people who come to counselling are then ready and appropriately in a place to accept counselling and to touch the deeper trauma. And our counselling attendance rate sits at 92%. It's incredibly high. The national stat on that is 60. When I sat on the Rape Crisis England and Wales board, I asked everyone what that was. It was 60%. And I went back to my team going, that means we've all got it wrong, not we've all got it right. What are we doing that stops people coming? And it was about practical issues, kids going into care, needing a new house, the perpetrator lives on your street, all of those kind of things that stop you touching the trauma because actually you've got other issues. We offer psychoeducation and peer support groups, and that's about not being the monks with the Bible, not letting the peasants read. It's about saying, this is what's going on in your brain, this is what's happening, it's absolutely normal, you feel like this, and using that information, how do you want to progress forward? We do that in a group, and to be honest, I did it because the Ministry of Justice said that we can't have waiting lists, they might cut the funding if our waiting lists weren't being serviced. So I set it up for that reason. And what I found from it is it's a shift left, it's a principle called shift left, which some of you might be aware of, which started in IT, and it's basically if you call to say your computer's broken, they pass you through to somebody and said, have you switched it on and off again? Spent so much time doing that they do that now on answer phone. So you answer it, it goes, before you go any further, please switch off your computer off and on again. They find that 60% of the calls drop there. So only a few come through to the more expensive services. What I found as a kind of side effect of our psychoeducation groups is that happened for our clients. So I did it as a SOP for the MOJ, to be perfectly frank, and to give people something. What I found is that people, the shift left principle worked. Some people didn't need anything else. Well, I've got it now. I know what's going on. I know it's not my fault. The guilt and shame doesn't sit with me. This is perfectly okay. Fine. Some just go straight into women's support or men's support groups, so they don't want the in-between stuff. So they're sitting in our less expensive services. Some then spend less time, and we can absolutely demonstrate they spend less time in the more expensive one-to-one services. So from doing that, giving people the tools and finding the support of others, we found a much better, quicker way of dealing with the need. And what we all want is people back out living a life. We don't want them in services. We also offer a professional advice line now, which works with other support agencies. So if you're working with a client, one of the things we found is that people in other services, the thing they were worried about is, if I get this disclosure, I'm now worried about what I need to do. And I was really impressed that people felt open enough to be able to share that with us, because there were some quite serious professionals going, I don't know what I'm meant to do. So they were taking a real leap of faith. And so we were going, well, we can help with that. So if somebody gets someone now who discloses sexual harm, they can ring us and we can go, right, this is what you need to do. You could do this, but you don't have to legally, this is your position. And we can take those calls. Those calls last month, the advice line just used to offer 2 or 3. We've offered 40 in this last month. So we know that that's impacting and picking up. And we offer specialist sexual abuse training. This is not, for me, about our service becoming huge. That's not what we're after. What we're after is people being worked with in the service that they sit in. So they don't have to retell their story. They don't have to go from place to place. They literally can go, this is me. This is why I'm sitting in drugs and alcohol, because surprisingly enough, this is a symptom of sexual abuse and you can work with me here. So we do that training around dealing with disclosure, around vicarious trauma, around what the impact of sexual harm looks like, and around how you can best work with that ongoing work. So that's kind of got a little bit more specialised. And some years ago, when I was sitting around listening to all the kind of coping, as I call them, coping behaviour services, and that's in no way to minimise the work they do, and I'm wondering, why is our service not got all of this when actually we're the underpinning cause? And then it was really clear it's because we didn't ask. We don't ask, we don't know the numbers, we don't know the numbers, we don't fund, it goes back and round and round and round. So we've got some really great commissioning from Barnsley Council. It's really forward thinking around Ask the Question. And from that commissioning, I went to the Centre for Expertise in Childhood Sexual Abuse, which is the Oxford University for our field. And it's full of professors and doctors and great researchers, and this is their only field that they work in. And I kind of said, we've got this money. This is a pilot project. This is how we're going to roll it out. Would you like to be involved? And I genuinely thought they'd go, run along, the big girls are playing. And what they said is, I can't believe you've got that far. We've never managed to get that far. Yes, please. So they're now actively great members of our steering group, which is the national pilot. We've also got Survivors Trust, a national membership group. I'm speaking at their national conference on this project. And we've got KPMG. We've got a data analyst on the team who's giving their time pro bono for this. We've got some local commissioners, and the big lotteries are looking to join as well in terms of national findings. The national findings from our research in Barnsley are going directly into the Home Office and the Ministry of Justice. This is a really seriously heavyweight project. And what do? It's really simple. It's so simple. We're just saying, if you're showing a coping behaviour of sexual harm, so you're in probation services, you're in drugs and alcohol, you're self-harming, an eating disorder, domestic violence perpetrator or victim, you're in drugs and alcohol services, you're in self-harm, any of those services, what we're saying is, if I was to turn up in front of my GP with spots, the first thing they'd say is, have you had any contact with anyone with chickenpox or measles? I turn up for my third lot of antidepressants saying I feel suicidal. What's the biggest underpinning cause? What I'm saying is, can we ask? Can we just ask that question? And if the answer to that is yes, how quickly can we get those people into specialist treatment so they're not continually coming round the loop and also draining the country of those resources? So we ask them just compassionately, something along the lines of, people who use alcohol to this level have sometimes had sexual harm in their experience. I'm wondering if that's your experience, and if so, would you like some help with that? Just as simple as that. What we do is we don't ask, so we keep it further silenced. And by silencing it, it's eating people alive, and they're in all our other services, screaming out that this is what they need. The first data for this is coming in, and just on first ask, so we've trained recovery steps is one of the services we're training. We're just completing that training now, but even now on first ask, 18% of their clients are saying yes. So that's on first initial call. This is my first assessment. I've just met you. I'm going, your name so and so, you're this, you're this, you're this. Have you ever experienced any form of sexual abuse? Yes, 18%. That's before we get to know this person. 88% of BSARC clients wish they had been asked and weren't. So this is huge. If we can get 10% of this town's drug spend, how much are we saving? 10% across the country. What about 10% of mental health spend? Where would we be if we could get that? If we could get straight in, if we can do the whole shift left principle and get people from our more expensive services into our cheaper services, where would we be? This work is now being discussed by the Welsh Government, which is why I contacted Jamie going, this is moving on and I haven't even really updated you. So my real apologies for that. We've been so busy on it that I haven't really taken the time to kind of update this group. And as I say, I'm sorry for that. But it's now in front of the Welsh Government. They're now including working with adults of survivors of child sexual abuse as their key strategic aim. And routine inquiry, which is what they're calling Ask the Question, is one of their key outcomes. And they're now speaking to me in BSARCs about this project. And we've now got a connection into NHS Wales where they're wanting to know what are we doing here and what can they learn from us. And I was sitting there going, oh, this is great. And I thought, geez, I haven't even told my own team where we're at and what we're doing, and they really need to know this. So we're now working with the Centre of Expertise. I'm working in York next month to do a talk there to York City Council and survivors organisations there about what we're doing. So it's working really well. And when we think about it, it's absolutely not rocket science. It's just really easy and it's so simple. But because we kind of have had a worry about it, we've maybe had some shame around it, the massive power imbalances, stopped us asking that question. And Barnsley will have slightly more sexual harm just because poverty is a vulnerability. It doesn't mean we've got more predators. It means we've got more vulnerable people, and poverty is one of those vulnerabilities.
What do you want to pause? Do you want to pause there?
Yes.
Open it up for any reflection. That's a really powerful journey in many ways, isn't it? That this has been on for a number of years, and it's really positive to hear that we've got some creative commissioners that are working with alongside you. So that will be.
Thank you. It's great commissioning.
I'm really pleased about that. So we just, if that's all right with you, just to give you a bit of time to just Leslie.
Thank you. I almost can't speak. It's stunning, really, to me to hear this stuff. I think you're absolutely right. There still is that level of shame, but also I think trepidation for people about worrying about making the situation worse for somebody by asking them. So, you know, past experience of kind of having conversations about this in other places is an anxiety from staff teams and things going, but if I ask them and then they're upset and I can't contain it, what will I do? So I think having that professional advice, having the training, having a protocol for how you do things is absolutely vital, because that gives people the confidence to do that. My question was, and also I think it's brilliant that Barnsley's leading the way, so I've just said that. Yeah, absolutely fantastic. But also that speaks to the creativity of your organisation and you for taking that forward, and I don't think you should underestimate that. I suppose my question is about people that are not necessarily being seen by professional services and what opportunities there might be around that. So speaking as somebody who was until last year Chief Executive of a Local Age UK, I know that our frontline staff in particular, you know, quite low level support staff, often got disclosure from older people because they were coming to the end, towards the end of their lives.
Yeah.
They might have been carrying it for 80 years and all of a sudden it was blurt. They were going to tell somebody.
Yeah.
And I just wonder about, you know, how when we're getting disclosures in that way, we're not asking the question, but somebody builds up a trust relationship and they might be the only person that person sees. So there's an opportunity, I assume, to kind of link those people into services as well.
100%. So all the training goes out openly anyway. So we started by what I called softening the market, is what I called it, because I knew that if I asked people to go straight into this, it'd be too big. So for a long time, we've been delivering openly on voluntary actions, training Canada, Barnsley CVS on the pod system. And then we went in, we're now doing delivery around the areas where I think the coping behaviours are more shown. Weirdly, age concern is one of the target areas for us, because there is that thing about how do you get somebody to be able to release that when they've carried it for most of their lives. Our oldest client was 81, our youngest was 8 months. So when as a client, we were working with the parents at that stage. But yeah, there is that. For this particular project, because I need to see the statistics in order to get this moving, I pick the services that we know for a fact our clients are hiding in.
Yes.
Yeah.
But the reality is people are hiding everywhere, aren't they? And one of the anxieties, I think, is that, you know, even in this room, there's a possibility that it triggers something for somebody. And so, you know, and amongst a group of professionals, there will be somebody in that room that it triggers.
100%.
So, you know, I think we all need to be aware and kind of conscious of that.
Barnsley professionals in our team, some of which I see regularly and will never not acknowledge I've ever met them before.
Yes.
So we do that, we deal with that kind of work confidentially, completely.
Yeah.
Or we'll arrange for them to be seen outside the town in one of our sister services.
Thank you.
Thank you, Richard.
Yeah, that's really powerful and a really impressive piece of work. What I was wondering is whether we're missing a trick in terms of some of the contacts we have in the hospital with people, particularly Amy sees an awful lot of vulnerable people, people with alcohol issues and so on, and whether there's any more we could do to ask those questions so that people come to us for other reasons.
Yes, absolutely. I think, especially as you say, the vulnerable ones. So they're vulnerable to lots of things, aren't they? We've been doing some work with Angela Fawcett around doing different pockets within NHS in general. I think there's something about data gathering is difficult because the systems, I'm quite lucky, my system's small, I can change it at the drop of a hat. When it gets bigger, it's more difficult for people to be able to change that big machinery to gather the data. But as well as, but we are happy to do the training within those services 100%. We just need any kind of contact to us.
I suspect that's probably an action we can take forward, a broader action between us all. It's a bit of a call to action, actually, isn't it? It's about us all taking. I mean, when I think about myself and adult social care, you know, one of the actions I will take away and say, hang on a minute, let's have a conversation, a full conversation about how do we, you know, support more practitioners in adult social care to engage in the training. Wendy?
Yeah, thank you for that. And I don't think you have to apologise for not being able to bring it to us because you've been so busy. I think that. But thank you for bringing it. And thank you for putting Barnsley on Mac as well.
Thanks.
But can I just get when people are approached who have been sexually abused when they're younger, they've held it so long to just ask the question once, I think will always get in there.
It would.
And can I answer your question about age? Age of care, why you're probably picking it up is perpetrator. They're probably past themselves.
I agree.
So there's no fear there.
I agree with
when someone don't tell the mum and dad, for fear of the mum and dad disowning them as well, because that's what perpetrators do.
Yes.
Put that in the picture.
And there is a generation issue that until the 1990s, raping in marriage was illegal. So we're looking at a generation that were brought up that way. So everything that was wrong was about the victim was wrong, not the perpetrator. So how do you change a lifetime's worth of belief? Is there, isn't it? But you're right, that we're now gathering the data. Well, we've tried to gather the data at several points. So one is on initial impact, which is why I'm really stunned it's 18% straight away. But within that journey, people will gain the trust and will say, and that's why I'm keen not to shift the worker to sit on another waiting list. Can we give you the skills to work with them in your service? Other than GPs and the like, which haven't got the time, they just need to get them out to a specialist support service.
I think once people have been asked the question more than once, it'll trigger something in their brain saying, yes, I've got to admit to this because I'll get help.
We're also we've also developing a range of posters now where we are having them in different places, targeted, which may say, you know, if you're experiencing anxiety, depression, or feel suicidal, many people have experienced self-harm, feel this, you can tell your GP. So we're trying to get those connections, and even if they don't, they may go, oh, that's the issue. I'll look it up myself and see whether or not I can find it.
Denise, did you want to come in? Yeah, I was just mindful in that you said at the beginning that already you're more financially constrained in terms of the support that you can give. And the very success of this is likely to increase demand, isn't it? Now, it's a question about sustainability, really, and how you see that, whether that's something that you're worried about.
I think what we're probably all worried about sustainability of lots of things. I think for me, it's about shifting money. So last year, BSARTS was on an £85,000 deficit budget, which we've carried. But the clients are there. I think if I was kind of going, I'm setting up a new football club, come and join, I'd have some concerns, but the clients are already there. What I'm saying is we're misspending the money. We're overspending the money in areas that we didn't need to. So we don't need more, we just need to slightly shift it. And if we can get to the symptoms, the causes rather, we can stop treating the symptoms because they won't be there. It's like we stopped having COVID because we gave a vaccine. We spent money on the vaccine to stop that happening. We get here, we'll stop that coming down the line. Prisons will be full of people.
And the courts, I mean, that whole, you know, digitisation of the courts, so get rapidity of action, I guess, through the courts is a real challenge, isn't it? I heard that earlier on. I've heard that from a few places. Leslie?
The last word on that note of sustainability. I know when we work in the voluntary sector, we kind of want to, part of that is, and I'm not saying this in a patronising way because I did it for 30 years, we do want to change the world. But actually, you've got a product here that if you're in the private sector, you'd be selling to people, you won't be giving them for nothing. I'm just wondering how much the Welsh Government's giving you to support you to talk to them, and how much other people are giving you when turning up to work at a conference. Because that's resource, and actually what you've done is created a product that other people want. And I just think we're not very often good at saying, well, I'll do it, but absolutely.
We are getting paid for my time.
Good. Well done.
We are getting paid. The other thing is, for me, it's about, we're learning the lessons, but how do we package it? Because you're right, we are looking to package this for Barnsley. If nothing else, I want Barnsley's name on it. Because our commissioners were forward thinking enough to invest. What I don't want it to do is get whipped out of Barnsley's hands. We do a lot of good things. Our suicide prevention stuff is brilliant. What we don't want to do is for it to go without us on it. You need to be driving it, and that's kind of why I'm sitting here, is how do we drive this? It will change the country, 100%. We will change the country nationally.
It's how you maintain control of what is your intellectual property, because that's what we're talking about, and we're often not good at that.
Yes, CPD registered all our training, copywriting it currently.
Great. Doing it.
The very final, you've got us all going here. The final one from the door, then we'll have to move.
Thank you for that. Very impactful. So I think it'd be nice to pick up a further conversation with you from a club learning point of view, because I've got the same comment in my mind about if only more people on the first time you ask would tell us that our experiences. Of course, people have usually had quite a traumatic way to get to us in the first place. But it really it can be quite advanced in therapeutic relationship by the time there's disclosure like that. We found, particularly with our perinatal services, which can be a key trigger, that our service users will confide in a peer support worker much more readily than a nurse or a doctor or someone with a uniform. So it'd be lovely to think about how we do some co-learning. And I can think of there's probably a cohort of our service users that actually be better accessing your services and the pathways we stick them on. Depending on, depending on the rate of disclosure, and then so I think it'd be useful to pick up a conversation, particularly on that training and learning.
Yeah, absolutely.
Because my other worry is we've got waiting lists with strict criteria. You've got there's quite a lot of gaps that people can fall down and then wait until they're really poorly to then drag them out into something that's worse. I think there's a number of things we could maybe pick up.
Yeah, I agree.
So first of all, just to really thank you. Please do pass on our thanks to all your team. Their commitment and their resilience. This is not an easy space to occupy, is it really? I don't think for anybody that's find themselves in this sort of situation in their journey through life, or indeed individuals that are trying to support people through for whatever, into adulthood or whatever it is. So thank you. Please pass on thanks to the team. There's obviously a bit of a call to action, I think, for all of us really, that we've heard the reflections that you shared with us today. Really, certainly for my part, I will take that forward in terms of adult social care. We've heard from Richard, and Bob no doubt will be, and she will be reflecting upon this for the hospital. Dawn will be following that up with regards to SWIFT and mental health services, and continue to explore, I think, together about what's the art of the possible really in this space. I can imagine people are sitting here with loads of things wheeling and whirring through their head really. So we'll make sure we share your contact details, if that's all right with you, and then people can take on further follow-up conversations with you, of course.
Thank you. Can I just say before I leave, though, it wouldn't be the voluntary sector without a pitch, would it? BSACS has never had a penny of health money, not one penny of health money. Half our clients have got mental health issues. Literally 722 of the 1,530 we see have got mental health issues.
Something for us to reflect upon.
Thank you.
I thought I can see by your face. I think you're just
through BNBC contracts.
Do you?
We
Is it in joint finance still?
we just transfer the money to the council and then they commission the service.
Right. Okay.
So yeah.
You don't get any kudos.
No, I know, but it's it's a team effort in terms of resourcing.
Yeah.
I think around here. What there's ever. Always more. If we had more, we would want to.
Yeah, the waiting list for our services is 264 at the moment. And when we say counselling takes 6 months to kind of deliver this kind of level of effective counselling, or court is 3.5 years, it's a pretty hefty list. So not as big as some of yours. If you're in the thousands, I understand that, but it is noticeably bigger. The numbers go 10% every year, I think. Services.
Your engagement and retention's really good though.
Yeah, it's great. It was the work on understanding that. Sorry, I know you need to move on, but when you hear a therapist going, I need to shift this person, and you go, talk to me about what? And they go, it's all of these. You put the other service in, brilliant, it works. Really bad, it works.
Well, there's definitely something to think about.
Really interested to understand who on your waiting list is on our.
Well,
that would be great.
Data exploration.
We have a psychologist comes in, Ben Haig comes into our team every month where we do joint work. Yeah, it took me 5 years to get that one set up, but he does come now quite quick. Yeah. Revolutionary. Thank you very much everybody for listening. Thank you.
Appreciate it. Thank you.
Thank you for the best descriptions left you.
Oh, she left. Yeah, she left. It's great, isn't it?
Okay, so no questions from the public today, so that's helpful. We've got minutes from the previous meeting on the 28th of March. If we can agree those as a correct record. If not, please do shout. Okay, thank you very much. On to the action log. Okay, action log. So there was an action there, Dawn. Contact Alex now, connect Alex rather into our Director of Services. Done? Yeah, sign that one off. Yeah, okay. The next one down, marked as number 9. That was to do with right care, right person. Oh, you're going to say it's not?
We've tried to figure it out. Literally, I've just noticed on page 5 of the minutes, it was linking to the NHS 111 mental health pathways. So it's finally solved.
Right, okay, then well, we can probably send you some information later today on that. Mark that as closed, I'll send that through to Dawn today. We set the place update as a separate item. That was a request, wasn't it? That's gone out today from the last ICB board. And then we're on to 13.1. Jamie, to pick up a primary care engagement with colleagues.
Yeah, so that one around the model that were presented and the option appraisal that Tracy had done. There's not been as much interaction in some of the events, so there's been specific engagement activity taking place with the LMC, with the clinical directors and other groups. So they have had input and view. Merv, and I think Tracy came to the clinical directors meeting, didn't she? I think the next step is around when we move to implementation, mobilisation, how to make sure the pathways are there, and then the role of primary care within the model. You know, we've got streaming and other things at the minute, but what would that look like, and how do we facilitate that? And Bob and myself and some colleagues are meeting with Tracy tomorrow morning to discuss that.
Yeah, I mean, I think the challenge for us is to get people in the same room. We're looking at the same issue with different angles, and something we've got stuck in a rut in before. So I think we just need to think about, you know, influencing and just making sure we've got a shared view on how we tackle the problem for the next 10 years.
Yeah, and I guess it's worth, no, Banjul, we were in a conversation yesterday, weren't we, around some of the opportunities in the going on around how we do things in the community a little bit different, some of the sort of proactive care, and we started out of hours, linking together, working in a more cooperative way so that, you know, different services respond as best meets the needs of somebody who might ring 111, be put through to the out of hours GP, actually might get a better response from urgent community response or linking to social care. We're talking through how we could make that bigger yesterday, and one of the things that came from that was actually how do we get input into that from ED clinicians who can inform actually the ones that are getting through. How do we turn them around? How do we make sure people are aware of the service and they actually link that? So that is about preventing and that front end and turning people around. It's out of hours, look at what we do in hours, but that's an important part of it and can link in.
So there's some helpful conversations progressing there. So let's close that off. Respiratory down 13.2. Jamie, can you update on those?
As far as I'm aware, Lynn has done those. So I think we've picked up the conversations and they're part of the sort of programme. So hospice linked in as far as I'm aware. No?
I've had no contact from Lynn at all so far, Jamie, and neither has anybody else at the hospice.
Right, well, let's get that one sorted, Sarah. We need to sort that one out. I'm aware the second one is concluded because we've connected Lynn to the private sector housing team within the council. That connection's made. Okay, there were a cluster of actions there from following Andy's helpful attendance at the place committee. Anything that anybody wants to update from that set of actions?
Just to say, I've been in touch with Andy to invite him into Barnsley CVS to have a talk about volunteer pathways and how we can help with those.
Excellent, thanks Denise.
Andy has some of the conversation with the PCN.
It was just nice because the presentation at our CQC meeting was a good example of the work we're doing with the Royal Voluntary Service. So that's linking with you, Denise, but just people going out when the patients are discharged to home. Are you aware of that one?
I'm not, no. So
I'll send it. There's a nice video. I'll send it.
It's the national, yeah, I've seen it, yeah.
Okay, that's great.
Yeah.
Yeah,
it's good.
I'll send that one too.
Lovely, thank you.
Excellent. And then yes, staff rotation of PCN and GP practices.
Yeah, I think that conversation's happened with Janie around where the options might not be in GP practices because of some of the challenges in getting that, but looking at some of the extended services, at scale services, so like home visiting and other things, how can some of the staff rotate in and out of there. So Andy, we're going to have a follow-up Mervan with you. I don't know if that's happened yet, but I know it'll be in schedule.
It's booked in for next Wednesday. I think just a word of caution is these aren't fully trained paramedics that could actually hit the ground and see patients and actually deal with patients as the current home visitors that we have. These are people who are doing a 2-year qualification with, I think, Hallam University, that need support from a mentor to make sure that their clinical skills are up to date. So they there's a kind of an education element to it as well. But we've got a meeting planned for next Wednesday. Janie and I meeting with the person from Yaz.
That's really helpful, thank you. So the majority of those, I think, can be closed off, given that they're well underway. Neighbourhoods, just a bit about neighbourhoods. We did feature neighbourhoods in the place report to the ICB, but just to cite you on some broader work, what's the conversation that's taking place that is happening next Friday. It's happening next couple of weeks.
14th, it is Friday.
And this is following a conversation I had with Emma, actually, myself and Emma Latimer, the place director in Sheffield, had with Citizens Network, who've historically you've done quite a bit of work around neighbourhood development. And it's almost like reflecting the fact that actually across all of the 4 places there's a lot going on around neighbourhood development. We've got a really strong history with all the work that we've done with the VCSE Alliance, our Stronger Communities team, 10 years on in for that. So we've got a lot of strong stories to tell in that space. Sheffield are doing some interesting work in a particular part of Sheffield. Doncaster have also done quite a bit of work that was led by Rupert Suppling as the DPH. There was a need for us to bring together some of that learning and reflection through a South Yorkshire conversation, with, I guess, a bit of a view to maybe working with the combined authority, developing a sort of neighbourhood strategy, maybe too strong a word, but something that can describe those principles of neighbourhood working. So it's a kick-off conversation. I've shared it with a number of people who are interested in that sort of space. So Andy Snell, the hospital's going to try to come. Jill, hopefully you can join us. Joe Minton from our team. It is a face-to-face full-day session. Anna Hartley, Phil Hollingsworth. So there'll be a small team of us that will be heading over to Doncaster, and I'll feed back where that takes us to in due course. Okay. So item 16 there on the list, the BAF IL17 and SY040. Believe they're being dealt with, unless somebody tells me otherwise.
They're still included in the registers, but they ask
The
around
actions.
updating the mitigating actions, and I think Alan and colleagues have done that.
Yeah, because we've raised it twice, so it should be the case. So we should close that off. Terms of reference, that's on the agenda today. So on the basis that hopefully we'll conclude our decisions on the terms of reference, we'll sign that off as green after we've dealt with the item. I don't think there's anything else on that action log. So place director update, a very brief update from me. You've obviously got the other report that went to the latest ICB meeting from Barnsley. We've mentioned already, this is the last week in Hilda House. We're trotting off and occupying level 4, a part of level 4 in Westgate Plaza. So in future, of course, that will mean some of our meetings will be in Westgate Plaza and the town hall. So just a helpful reminder to you all in terms of your diaries and car parking. Don't get caught short with any of that. So that's really helpful, and thank you to the team that have worked on that transition in no mean feat. I've concluded actually the portfolio leadership work. We said, didn't we, in terms of settling the structure down within the ICB. We then have a portfolio leadership schematic to share with you all. We've finished that off. That should be going out. Go out this week. Yeah, we'll send it out this week. The idea being that you'll see who's leading on what bit of the improvement jigsaw in the ICB team, and it'll give you a point of contact to pick up. We had a really helpful visit from Doncaster Council, the Chief Exec, and the League for Economic Growth and Doncaster Hospital's Chief Exec, who were suitably impressed with all of our collective efforts around economic regeneration and our work on health on the high street. Hopefully they took away some nuggets from that visit. Interestingly enough, at the time in which I wrote this, it was before there was the announcement of the election. So we did have Nick Hislop that was planning to come to Barnsley from the Department of Levelling Up on the 31st of July, but I'm sure that won't be happening. It'll be rescheduled accordingly, but colleagues in this room no doubt will be wanting to be involved in that. He's very interested apparently on our performance around discharge and and adult social care's performance. So and how just generally about how we're managing demand. So that will be a useful conversation. Lots of things to celebrate from the awards, Swifts Awards ceremony, and of course the hospitals last Friday as well. Both of I didn't manage to get to Swifts, but I understand there were fabulous events, and a few of the awards certainly from Swift are reflected in the update today. We've got the annual review slides that we had with Gavin and colleagues from the ICB for Barnsley Place. We'll come on to that on the agenda. The Autism Summit, Jamie, you want to say anything about the Autism Summit? The
So
autism
they would have
strategy?
yeah, so it would have follow up. We had the initial summit was February. We've had
Yeah.
to follow up with all of the same stakeholders together in April to begin to look at the pathways, and there's follow-up workshops around sort of the assessment process and others. There are some specific things that we're taking forward or trying to take forward a little bit quicker to look at where we've got some real pressures in the system, and that's around mainly the ASDAP team, so the Hospital Community Paediatrics, who deliver the assessment for 5 to 18-year-olds. With a bit of movement on 17-year-olds. So Bob, myself, Carmen, and Sue Threadgold got a conversation next week. We want to explore the opportunities around how we can do something that is an interim, short-term thing whilst we look at the longer-term solutions and the provider collaboratives do and others, to make the best use of the resource and manage our capacity maybe in a slightly different way, which may mean that in services where we've currently got no waiting lists, we might want to see or accept that there might be a little bit of an increase in a waiting list, which will help us to offset and address some of the challenges we've got in children's, because it is a significant wait at a quite stressful and challenging time, obviously, for the children, people, families, and also for the service, because I think it's having a real negative impact on the people that are trying to do their best and based around that. So yeah, that's what that's around.
Thank you.
Just on that, the goal of that work is to come up with some innovative approach to getting them to expense reasonable.
Yeah, the immediate.
We've talked about for a long time. I suppose is a reason.
The immediate bit is looking at from a commissioner perspective, I guess asking our providers. So you've got limited capacity, but others. So some of the adult services, children who have got some of the specialists, who've got some people who could do some parts of the assessment, and that might reach into other parts of local authority services as well. So we can bring that together, use it in a slightly different way to try and bring down some of the weights. There's a longer term piece around. There were conversations with children's services leads and local authority chief execs, ICB, that Wendy attended a few weeks ago around how do we actually fundamentally shift the model, because all we're seeing at the moment is a increase in people doing a need for, wanting, whatever, but the assessments and that coming through. So how do we shift that from a medical assessment model to something that is about meeting needs regardless of assessment? And one of the things that we're doing linked to the longer term work is mapping out actually all the services. Because initially we were told, oh, all our services are universal, people can access them, they're needs led. You don't need to have a education, health and care plan to access services, and you don't need to have an ASD assessment. And then when you dig into it, actually there's a whole range of services where you absolutely do.
Yeah.
So we're trying to sort of understand that, and how do we overcome that so that people receive the support that they need.
So the goal is to get a plan that coordinates the various different bits of Barnsley to get those weights down in. So the plan we can have through here, because it just feels like something we've been talking about for a very long time. It's got worse, not better. And I'm not convinced I've seen anything. I just think there is a plan. I think we rehearsed the problem.
Yeah.
But I think we've got.
Yeah, I think we're going to come at it from two different angles. To be fair, I mean the conversation that James just referred to was basically a convening of conversation between a few DCSs, Directors of Children's Services, people are leading the ICB's MHLDA programme of work, bringing together a couple of the chief execs from the local authorities, and which really was sort of a real exploratory type of conversation. And for my part, one of the reflections we've had is about actually where is the SEND agenda landing in terms of a leadership responsibility within the ICB, because it does toggle across both the Children and Young People's Alliance and the Mental Health Learning Disability and Autism Provider Alliance as well. So there's a whole question about where's that leadership role for us. In the end, we ended up with a bit of an action card that Meredith, who's the DCS in Sheffield, was going to go away and come back with a bit of a proposition, but that she would draw on my sort of knowledge linked into the collaborative, draw on Cathy Wingfield as the chief nurse's role to sort of start to bring and shape something that we could do something with. And I was actually, funnily enough, just following that up this week because I've not heard anything following that initial gathering of individuals. So I was going deathly quiet. So I was chasing that up with Carly Speechley about what's happening. I've not had any contact when we're going to get a bit of a proposition coming forward, because it's a complex picture, isn't it? So it's about what are the things that we can grip at place to improve the situation. What's the MHLGA collaborative doing, and what else across South Yorkshire system do we need to do? So I think it's about actually pulling it together into a coherent plan of action.
That's kind of where I'm sort of pushing it a little bit, because I think our system set up in a way that these sort of issues aren't anyone's. That everyone's and no one's problem, and therefore nothing happens. And yet the patients and the families are just left to linger on.
It should be just one plan. In my mind, I just think it should be one plan that everybody's facing into. If they get discharged, or bits of that jigsaw might get discharged through the MHLDA Alliance, bits might be done by a place, but at the minute we just need one plan. So that's what I'm striving to get to, Jill.
Yeah, just I agree with Richard. We have talked about it a lot, and we've mapped through the problems and the issues, haven't we? And I think we are getting to a bit of a crossroads now, aren't we, where actually we need clarity around what the actions are. And I suppose one of my pleas, and I know I don't manage children's services, and I'm sure Carmen will raise it, is actually there's something about the assessment and the treatment and the specialist elements service where actually these children are not neatly wrapped into those specialist services. They touch a lot of other services out there. And actually, how do we galvanise doing the right thing for these children and young people in our broader service offer as well? So I'm really keen that we continue to have that conversation, not just about the specialist element of service.
I think that's important, and broadening it out. And it has been the problem, but actually each time we come back to the question is, are we actually trying to address the right problem? Because we started off, honestly, is what do we do then to make the assessments faster, get more capacity, and do change the workforce? But actually, the fact that we're seeing such a massive increase is the driver. So what has resulted in that? Have we seen a massive increase in, yes, probably awareness and therefore people wanting to come through? But are there other things that have stopped coming? And we got into last time just some of the issues around reduction in the level of universal services that give some of our children and young people special education needs for others, access to social experiences and other things that allow them to make friends and do. That leads to, just one example, and then I'll finish, around the push for a autism assessment, because that's one of the services that you can get in there is around then access to short breaks, and that's for the parents. But actually, when you speak to the parents, the reason they want to access short breaks isn't to give them respite, the children with autism. It's to give their children the opportunity to go and meet other children in a social setting where they can spend time and do interactive activities and other things, but they can't go to that support and service, and there's not a universal. So some of them things just push through and drive, and got to address both bits.
And there's some policy influence stuff as well that we've got to actually galvanise our collective leadership on some of the stuff, trying to influence nationally on some of the stuff. Sorry, Leslie.
Just as I'm listening to that, I'm just reflecting on what we just heard Lynn say. Yeah. And I'm thinking, this whole thing about shift left shift, whichever way you want to say it, is you're right that actually we catapult people into some services that's not necessarily the level that they need, because we haven't got these other things lower. Low level sounds wrong, but these other kinds of offers that might meet a need and not. It's just a really interesting conversation, I think.
We'll look at that psychoeducation.
It's exactly that, Jamie. As you were talking, I'm thinking, yeah, we've got some learning to do, haven't we there? Yeah.
Sorry, I've talked about this quite a lot, but I think I'd be really remiss if I didn't sort of point out but we've got a situation it's quite a big waiting list and it's getting worse. So imagine if you're the lead clinician who's professionally responsible and accountable for the people that are waiting that are non-assessed, and it's getting worse every week. So I think everyone really welcomes the review of it, the potential ways forward and decisions. Other areas have commission independent sector support. It's very expensive. It's not produced returns. Other areas actually saw it on the news. It might not be what we want to do, but look to the thresholds. In the first instance, we're trying to get together as a team and say, look, what can we do with what we've got, which is, I think, a sensible way forward. So I just wanted to just have that context.
I think that's right. That's the conversation we're trying to have. Is what's the art of the possible with what we've got? If we put our creative souls to all of that and be really honest about risk tolerance in amongst all of that, what's the choices we want to take?
So there's workforce issues with it as well, isn't there? Just getting psychologists in.
Only a couple of other things there on there, really. Wonderful creativity and wellbeing week. I really enjoyed that, and so many other colleagues were there joining us on the table. Really brought to life the impact that connecting people with creativity can have on people's mental wellbeing. That was great to see, and just a bit of a nod to the 10 years since the Care Act stuff, really, and first podcast I've ever done. I've not listened to it afterwards. Anyway, there you go. But it's just sometimes when you just take a breath, you do realise how far you've come actually in terms of that. So that was really, really helpful to do. Okay, Sheena, over to you then for the ICP.
Yeah, so it was only yesterday, so I have shared the slides with Leanne thank you, to send out. So I think they're quite helpful anyway to sort of illustrate the things that we discussed. So we talked about the Children and Young People's Alliance and an update on the Health Equity Project, which was really useful. And actually, I've just been to the Children and Young People's Conference this morning in Sheffield, which was really, really good. Really heard a lot of good feedback from young people about their experience of services and what that impact is of not getting that right sometimes. And actually, one of the things that I think it'd be useful for us to think about is a kind of ask for us, really, I guess, is, I listened to feedback from young carers who were saying, some of their challenges around accessing services and actually, the barriers that they face because people don't know they're a young carer and so won't give them information and so on, even things like pharmacy and really good examples like that. So I was wondering if it's something that we might want to consider as a system around a carer's passport, which I know Sheffield Children's are embracing. It might be something for us to consider as a system as well around how we enable and access young people to have that sort of passport into those conversations quickly rather than having to explain all of the time. So just something to take away from there that kind of made me think about some of the things that the Children and Young People Alliance are doing. Separate piece of work, but one of the things I was quite surprised about on the children, and Chili Pep were there as well, so they're a really good advocate for young people, and a lot of work happens in Barnsley as well. So that was really good. But really interesting point about spending local authorities for children is way overtaking older people, and actually, again, that preventative agenda becomes really important again, doesn't it? So that was good. And then we had a really fascinating, if anyone's fascinated by data, I am, an insights project around building a connected data platform across South Yorkshire, which again I thought was brilliant. And I know lots of other areas are already ahead of the game, but the fact that we're on this journey, sort of doing this, really helpful. Really kind of important things around, developing those communities of practice and joining together our analysts across the board, because actually, translating the numbers and what it means is really critical to being able to take action, isn't it, really, when we know there are challenges. And also using AI in that sort of approach as well, really, in that really kind of innovative way. So I suppose, again, a question for us is how's the place board going to link into that? Because I think we have got a challenge around the data here, haven't we, about what it's telling us and whether or not we've actually got the right information in front of us to make decisions about the population challenges around health and care in Barnsley. So again, something to think about. And I don't know as an ICB whether you're connected, like, the team are connected into that, and how quickly we're going to kind of be able to access some of that intelligence and insight that's going to come from that project. And then the last one was around, there's two others. Rich is going to pick up the show for cancer because I had to leave, but Work Well was the other update that we received, and I think we did an update previously around Work Well, but South Yorkshire ICB along with the Mayor Combined Authority have been selected as one of the 15 pilot areas, so we've got some access to funding, particularly focusing on mental health and MSK, so helping people start, stay and succeed in work. So again, that I think will be really useful, and sort of I think we're just working through the practicalities around how that's going to be delivered, and they're recruiting a Work Well integration lead for 12 months as well to sort of deliver that. So again, I think it's about how we're going to access that in Barnsley, particularly linking it up with the other piece of work around what's it called?
Pathways to Work.
Sorry,
Pathways to Work.
Yeah, that's it. Thank you. So linking it with that. So yeah, that was it. And Richard, were you going to pick up the South Yorkshire?
Yeah, just before I do, just on that last point, I think it's always a difficult thing at the ICB to know how much of the various pieces of work are Barnsley related, or in my role, I'm in a Rotherham role on that committee. But in terms of, you don't know whether we're talking about Sheffield or South Yorkshire sometimes, so just probably often good to get it broken down a bit. Anyhow, the cancer bit. So there was a presentation by Emma Latimer and Julia Jessup from the Cancer Alliance on a sort of strategy which is called South Yorkshire brackets and Vassal first brackets shows up for cancer, which is intended to try to address the sort of late diagnosis of cancer we know we have in our region. So the sort of branding that sort of says things like South Yorkshire Vassal shows up, Barnsley shows up, Doncaster shows up. It's obviously been worked up to quite an advanced level. I don't think seen it before. There's 5 bold ambitions. I sort of mapped that phrase of bold ambitions that's in the ICB strategy. These are cancers recognised and treated as a long-term condition, to increase participation in cancer preventative measures, close the gap on cancer incidence rates between the most and least deprived areas. 3 in 4 cancers will be diagnosed at an early stage, and to reduce the number of deaths from cancer in people aged under 75. So that's what they're set out to achieve. There's a sort of advertising campaign there that looks like it's focused on something called peace of mind, to perhaps raise people's awareness of kind of symptoms that might be a early sign of cancer, and to get them to go and see their GP, which obviously I sit next to a GP when this was being discussed, and I think GPs aren't necessarily enthusiastic about having lots of people with very mild symptoms going to see them at the moment, I suspect. But it's also looking to get us to make pledges about what we would do in terms of our contribution to this work. And there's an engagement event which rather unfortunately was timed for the 4th of July that Oliver is going to lead. That's going to be rearranged for later in July. Maybe I think there's a 11th to 12th. So it'd be good if we can make sure we've got some Barnsley people at that meeting, just to sort of probably launch this and flesh it out a bit. What's it mean in practice for us?
It's really helpful. We'll look out for that and make sure we've got a strong voice in that space. So thank you for that update. So it's ever helpful. I'll pass on to you if that's all right for some of the other bits. I'll take the point about the carer's passport. Emma White is our lead for us for carer's strategy. So we'll check out where we're at with carer's passports. I'm aware we've done some stuff around, haven't we, on carer's passport, but I'll just check and then we can come back with an update on that. And actually makes me think we should probably have a focus on carers at some point, forward plans. So we need to think about that. So just note that as an action in terms of the forward plan about picking up the carer strategy overall. That would be quite useful. Digital, Jamie, do you want to come in with digital stuff?
Yeah, so I guess, well, on a couple of bits. So on the digital, we are LinkedIn, and obviously Kieran have presented that, and Barbara sort of LinkedIn. They've been working with our health intelligence or health equity and intelligence group. I don't remember the INE. So we are LinkedIn. Our ICB data people have been helping to design the platform. It goes further than we've done before, because if we get it right, it'll bring in primary care data as well. So federated dashboard. So I was going to ask, the question that you came to it around timing. So when we'll start to see some of the data that comes out, that we can start to make some intelligence with. So we are linked into that through colleagues, and we'll make sure that we bring things in on work well. So it's a slightly related point, but another opportunity for Barnsley. So that bid had gone in, and we've been successful from a South Yorkshire perspective. DWP sort of sneaked out, I think, but came out another opportunity, another programme for employment advisors in MSK services, which with colleagues came across and found it had not necessarily come through an ICB route, but the expectation was that ICBs would be the ones submitting on behalf of providers. So that went out to other places, but actually there were an issue around timing and other things. So we are putting forward a proposal to do that, but the South Yorkshire ICB bid will only be the Barnsley Swift element. So we'll be the only one.
We got us act together.
So good for us, and some work that can then perhaps be worked out. So I guess there's something just about making sure we're linking them employment advisors with
Absolutely,
the well ones.
We thought it linked as well, Bob, with the work that we started around waiting well and fair.
Oh, yeah, great.
As well, another strand of that, really.
Broader work. And then the other bit around the Show Up for Cancer. So I did have a conversation with the people that had designed it, and Julia, probably only a week or so ago, and it was the same, Richard. It had got to the point of having all of the stuff worked up. It's been into the Cancer Alliance, as far as I'm aware. So some colleagues have seen it, but as a document. So I were asked and look at how we bring it in, also how we get it wider. And there's a Barnsley 2030 board. On the 10th of June. It's in the diary, but I've not seen anything. And if you have, Bob,
no,
because Mark's moved on, hasn't he? Mark Hemshaw will organise that. So there's one in the diary. So we're looking to try and get a bit of that presentation there, because what that'd do is open it up for college, football club, and all in college and the other people to sort of share. So I'd said I'd do that, and then also consider whether it maybe comes into here as well, to make sure that all partners can see that and sign up. And obviously it does have an impact, doesn't it? These campaigns bring people forward, but if it identifies people at the earlier stage, then it's got to be a good thing. So we'll try and make them links in.
Very good.
Just following up on the sort of data aspect. So in terms of the insight, I think maybe it's timely for us to have maybe a conversation, a bit of a development session as a board about what that data should look like for Barnsley, because if we're kind of inputting into what does that look like when it arrives, I think it should answer the questions we want to answer, really, and maybe we don't know what those questions are yet. But maybe we need to spend a bit of time, because I don't think we're there yet, are we, in terms of understanding what questions we want the data to answer. And I think maybe we spend a bit of time doing that. That would be useful, really. We've got that picture so that when the data is ready to go, we've got a set of questions that we want answering. And if there is some gaps in that data, then there might be an opportunity to shape that in the wider South Yorkshire.
Yeah, we could certainly put that into the forward plan, really. I mean, I wanted to come back on the ICS data thing, because I think it's an observation I've made previously, is that this is an ICS data, it's an ICB, it's an ICS data strategy. And to my mind, with my local authority hat on, it hasn't been socialised at all in our senior leadership team within the council. So my question is, how can we, it's going into the ICP, but that's not the only journey it needs to take. And I don't believe it's personally for me, I don't believe it's been collectively sponsored as an ICS data strategy, and know that people at different levels, different roles are engaged in the conversation. I'm not really engaged in the conversation at this point. But if it's going to be an ICS strategy, it needs to be. Sarah Norman, the chief executive local authority, needs to be aware of this strategy. You know, potentially the leader does need to be aware of it, so we can, you know, reflect on it, contribute to it, and make sure that it's part of our priorities within the organisation. And I still haven't seen any of that happening. So I do need to go back to Kieran just to flag that back with him again to say, when is it going to be scheduled in appropriate other executive forums?
I suppose
I may be being unfair, but I think that's my own observation right now.
yeah, I mean,
It's supposed to be benefiting from.
yeah, no, absolutely. I think that's right. I suppose that's what I was getting at with that kind of kind of conversation about what we need to know in Barnsley Place.
Yeah.
And obviously, you know, local authority colleagues are really important in that, as are, you know, our voluntary community sector.
Yeah.
And you know, that data might, you know, be missing from the piece, and we actually, but I think we need to start with what are the questions we want to answer, really.
I completely agree. Let's start with a simple.
And actually that you know, having other colleagues who are part of the place board already anyway, aren't they, in that conversation would
Just it's the principle I'm making more than anything else. If it's an ICS sponsored strategy, then there's a path for that, isn't there? Richard?
Yeah, I think it's tricky, and I think everyone's very well meaning about what they're trying to do. But perhaps link shows up for cancer and the data strategy and a few other things that you kind of find out about almost by chance, quite a late stage at an ICP meeting, where actually it's not really ICP, it's and you know, there's 8 statutory NHS organisations in South Yorkshire, plus everybody else. And I guess, is there a case that we should bother at an earlier stage? Do we want strategy? What do we want it to look at? I think often we find people have got on, beavered away, come back with something. You're not quite sure what they're trying to achieve, or the assumptions have been made there. So I don't, you know, it sounds a bit ungrateful to sort of, you know, to say that when all this work's gone on, but I don't really know whether that's addressing our needs or what our commitment to it is. So, for example, on the data one, they were sort of talking like all of our analysts across the organisation is somehow part of this wider analytical team. I think we've had a conversation saying that whether we're giving up any analytical time or not, and Swift presumably also get a proportion of that. So I think whether it's a senior leadership question perhaps in the ICB about whether we need to be cited more on the work programme, and I'm not sure we've got a veto on any of it, but involving us early on, or at least getting some kind of agreement about we need one of these, might be helpful.
About legitimising things, isn't it, in many ways? Sorry, Leslie, and then Roxanne, did you have a way?
It's on the agenda for the, assuming it's the same thing, it's on the agenda for the board development, ICB board development session on Wednesday next week at 11:30. So since some of these key points, really good place to sort of bring some of that up.
Yeah, well,
while it's live in our minds, then
yeah, it's good. Thank you. Let's note that down as well, please, Roxana.
It was just really just the point around data. So we have lots of data, but we need intelligent data that tells us what we need to then do with it next. It's not just having a load of information that then just gets landed at you in terms of lots of different dashboards. And I have gone on and checked some of the stuff already that's been published through Kieran's team. And some of the things are just blank, there's nothing there. So it's kind of understanding the timeline and understanding the point at which we will get something that is intelligent enough for us to be able to do something with it. And then back to Sheena's point, what questions is it that we're trying to answer? And I understand the linking in with the health intelligence group, but there are other people, aren't they, involved in a data and intelligence conversation. So where are those conversations happening? Because I haven't been involved in any conversations, and I'm getting a sense from around the table that not many people have. So I suppose it is about that engagement plan with some of this. Otherwise, it will just be a platform that sits there that nobody uses. I think we're just in danger of creating something that'll be full of load of information that then nobody knows where to start, because it'll be like looking for a needle in a haystack in terms of what it is you're trying to do.
Well, there are 1,000 asks.
Yeah.
And actually, let's get it down to 10. I mean, to be a bit random. Let's get it down. What are our priority asks in that space?
I guess there's a broader principle of picking up on that. I mean, how many times have we seen this? Something that's been developed in a dark room and then people don't engage with it. But for me, there's a bigger principle about how the ICB works sitting across two. We're supposed to bring together in partnership. So it's really interesting that this has happened. And there hasn't been a group of us around the room putting energy into defining the scope and then what we're going to do with it. So there's something there about that way of working that feels, yeah, well, it doesn't pick up the narrative that we hear about ICBs and Ps and the purpose.
Leslie, I can helpfully reflect that, your collective feedback next week at the ICB's development session. On the work well, we've also given it quite a bit of our place partnership delivery group in June on bringing together the work well pathways to work stuff and getting a deeper understanding about how all of this stuff's going to hang together. Yeah, so we'll feedback in due course on that. All right, thank you, Sheena and Richard, for that update. Item 11, Jamie and Roxana.
Yeah,
Oh, sorry, yes, it is just Jamie. I should mention the financial, we have moved the financial update into the private agenda, just to let you know that's what we get up later on today. So Jamie, operational planning.
Yeah, and conscious of time, and lots of people have been involved. So all we wanted to bring, just so that we'd shared it, was the final position as it was submitted, which is around the South Yorkshire plan. So a number of, and this is against the sort of performance metrics, so it's the activity and performance as opposed to financial, which we'll cover off separately. So the table includes all of the metrics, whether they be performance or activity, that we have to submit against. I think in the main, from a Barnsley perspective, we were in quite a strong position in terms of what we were putting through. I think I'd probably pass on from colleagues who've been involved in the more detailed conversations our thanks for the approach that we have in Barnsley, particularly, and with colleagues as well, but there's a lot more of the indicators that are hospital related from a national perspective, and we have a much better experience of the planning round where we work more cooperatively together than some of our other places. So got us into that good position, sharing our understanding. There's a couple of areas where we're not quite in line with what the national expectations is. One around elective care, which is around outpatient attendances, where there's a procedure. So that's slightly below, based on where we're currently at and a realistic position. So it meets what we set out as a 46%, but they were asked for us to push further to 49, which is why it's showing us red. So we're meeting that. Across others, our plans are in line with expected or better. That's across primary and community, elective, cancer, diagnostics. We'll come on to some of that in the performance reports. We're doing quite well on them already. From a mental health perspective, again, planning to plans that were submitted indicate that we will achieve. The only one where we didn't quite push to the target, and there's a change in focus around talking therapies away from just pushing big numbers through to the ones that move to recovery and make reliable recovery. So a change in the metric, but there's still an expectation. You can achieve that by significantly reducing the numbers that you put through the service, and targeting those that might be easier to support. So there is still an expectation around that, but we've not pushed as far as perhaps the national expectation would have, and that's based on two things. One, the current performance, where we've seen an increase in the numbers accessing talking therapy services, but not to the level where we would have expected in 2024. And that's not a negative on the service as such, is the demand that's coming. There's access to other areas, but there were also conversations around continued investment as part of mental health investment standard in that service to allow them to grow further and open, which is not sort of progressed. So therefore, to push to a level didn't feel appropriate. So that sort of covers off where we are. I guess it's worth saying, whilst that's our plan and our position, there's a lot of work to do to achieve that and to actually hit both the activity elements and the performance elements in there, whether that be A&E stuff and continuing to improve in that area, or whether it be elective recovery or growing capacity in primary care. So there's lots to do to achieve it. I'll cover the other under the performance report.
Yeah, no, thanks. I mean, we've kind of gone with safe assumptions, haven't we? There's two things for me. I think that the outpatient procedures, we've been doing the work, just not coding it right. So we're tracking it weekly at the exec team meeting and just spoken to all the services about expectations and just getting that right. So I think that'll get resolved. Any attendances, I mean, it was pretty level last year across the year. Certain days, obviously, bigger than April's above 10% increase year on year. So it's way out of kilter with that. Once already we're struggling, and it reaffirms the work that we need to do and all the rest of it. But it just shows you what a volatile situation it is.
Most definitely, Richard.
Yeah, the thing I'm not really clear on about also the commitments as a place is the role of different partners, particularly I suppose I'm talking about hospital activity for now, but it might apply to this as well. So, Barnsley Hospital has already achieved the diagnostic standard for next year pretty much, but a lot of our activity is also through Sheffield. So when we look at the performance report, we have Sheffield bits and Barnsley Hospital bits for the acute hospital bit. So is this a commitment on Barnsley citizens or basis, or is this a commitment to the organisations that are around this table today? Because I'm pretty confident the BH is achieving the various things we have to do this year. I'm not confident that STH will. And so, and if we're advocates of Barnsley as a place, as this board, how do we make sure that we don't think that just because someone goes to Sheffield, that's okay to wait longer for something?
That's really helpful reflection. In some ways, it's also a bit of a reflection we have from the annual review meetings. You've got the slides are in the pack, aren't they? Where we say, well, actually, we've had a really helpful annual review conversations, but some of the challenges that we experience at place are actually challenges that are owned by another part of the system. So what could be the role of, what's the role of the ICB actually in many ways in terms of harvesting all of that insight it's getting from the 4 places and actually demonstrating in some ways that there is grip and accountability, sometimes harder grip and accountability in some other parts of the system. And we haven't got an answer to that yet, Richard, as yet. I think it's something we have to explore in a deeper way. Certainly, I do feel more confident now that we've got a director of performance in place with Sarah Perkins. It's her name, isn't it? Sarah Perkins. That she will be able to be a key role, I think, with the ICB in terms of pulling all of that insight and intelligence together and offering that sort of connectivity between performance and improvement that I think we at times struggle to see. That's my take on it at the minute.
I think the positioning there is obviously the combined position, isn't it, for South Yorkshire, and that includes the bit on the right hand side. The column is what Barnsley Hospital put in, and we'll try and make sure we reflect that and the work that the performance report that we've kicked off with Sarah is to try and look at that whole performance framework for the ICB and the interplay, so that what we get here is something that's much better than what I'm going to be sharing in a minute in terms of timeliness and appropriateness, so that we can see, because one of the things going off to Barnsley Hospital's figures, Sheffield Teaching Hospitals, Doncaster's, Rotherham's have come together. It's more difficult so we can have a conversation here around what's happening in Barnsley Hospital. But I rely a little bit on Doncaster colleagues and Sheffield to be having them conversations, and we can't always see, it's not always as clear what's happening and what actions. So I think there's something about us making sure we do get that from a Barnsley perspective into it, so we understand where there are some challenges that have been addressed elsewhere. So they are in a very different position, some of our providers are.
Yeah. Okay, thank you. So shall we move on to frailty or ageing well?
Yes, yeah, thank you. So I've called it Aging Well, reflecting on some previous conversations about how much people like the term frailty. But you'll see frailty is used quite a lot in slides as well. So there's still more work to do Yeah, thank you. So hopefully, I know everybody, don't I? Yeah. Hopefully, you've all had a chance to review the slides. We've rehearsed them once at Place Partnership Delivery Group already. I'm not going to talk in detail to all of them, but just I'll give a bit of background, and then I'm going to just go through the fourth slide, which is a bit of a why, what, so what. The subsequent slides are a bit about where we've got to with the individual projects, which I'm happy to talk to or pick up any questions from. So just as by way of introduction, frailty, it's a long running sort of focus area for the Place Partnership. And we've done a lot of work over previous years. I've listed on that slide 2, some of the pieces of work that are more about what we're doing around prevention or what we're doing in primary and community care. What they don't talk to is all the work that's going on, particularly in urgent and emergency care, so the virtual wards, intermediate care. All these have a very significant impact on frailty, but this is more about how we are increasingly screening, assessing, and providing preventative treatment or signposting preventative treatment in the community that can hopefully reduce the risk of falls, reduce the risk of delirium and the other sort of frailty syndromes, which will have a positive impact on our patients and also on use of non-elective care in hospital. So with that in mind, we had a bit of an exercise talking to leads across all of our partners, and thank you to colleagues that were involved in that, where we sort of went through, this is where we are in terms of some of the work that we've been doing, and this is where we are in terms of what's the data showing us. And on slide 3, it shows some of the information that we shared at that conversation, and also some of the key points coming up from the data. So whilst we've been doing quite a lot of work on frailty, we're still not assessing and supporting enough people around managing frailty, and we still see high levels of falls and hip fractures, and various other sort of headlines are on that slide. The fourth slide, which I'll just spend a little bit of time on, so it lists the 5 sort of priority areas that we'll be working on this year, with a sort of efficiency demand management approach. So the first is around screening and assessment. So I said that we have relatively low levels of screening assessment of frailty as seen in sort of GP clinical systems. We've also, as you'll know, we've seen quite a lot of growth in some of the services out in communities that can support people around frailty, particularly in the community and voluntary sector, and also in primary care with growth in services like social prescribing, health and wellbeing coaches. So there's a bit of a mismatch in terms of, you know, we have a need and we have a service offer. We're not necessarily seeing people get into those services, and that's why. Well, it's one of the reasons why we compare badly on some of those headline indicators. So the last release of public health outcomes framework around emergency admissions for falls, it's quite sobering in that we had the highest rate of any area in Yorkshire and Humber, very significantly higher than the regional and national average. So it shows there's work to do. So what we're planning to do this year is sort of continue in some of the work that we've been doing last year. So that's been around providing holistic assessments in primary care for people who are at risk or have sort of low level of frailty. We did about 1,000 assessments last year, and that has just shown some of the early data does show that that's impacting on use of non-elective care, although it's quite early days in terms of seeing that play through. What we want to do is expand that, and what we want to do is sort of be more targeted at sort of the mild to moderate part of frailty. So last year we looked at some of the pre-frail, we're sort of moving into more of the mild, moderate frailty. So that's sort of the centerpiece of it. But we'll be continuing to work with all of our providers to increase use of the Rockwood score, increase signposting into services like Blind Older People's Activity Alliance, and some of our primary care services. So we'll be doing that as well, but the focus, the centrepiece, is that work in primary care, which is part of our practice delivery agreement in 24-25. The second project is a project that's being taken forward through the collaborative between primary, VHF, Swift and the hospital, looking at a rapid access clinic for frailty. So why are we doing that? Well, we see relatively high use of emergency care for our frail population. There's a caveat to that, is that's all modelled, sort of estimated, who we think is frail rather than who has been clinically assessed as frail. But if we compare ourselves with other parts of the region and the country, we have relatively high attendances and admissions for people who are frail. And we have it reported, and Jill might want to expand on this, but the patients who are being referred into hospital for admission or A&E attendance for investigations and treatments that actually could be provided in the community. So there's an opportunity, we think, by providing rapid access in a community setting, we could avoid that hospital activity. It is a pilot, isn't it? And we're going to focus on a 2 or 3, I think, GP practices initially, and assess and learn to see whether it is, whether we can provide similar or better outcomes for patients, and whether it's cost effective. And we know this is a group of people that don't particularly want to be treated in hospital and all the risks around being treated in hospital. So there's potential benefits of supporting them better in community.
I suppose the key thing with that is we want to start small, because if we focus on doing something really big, we'll not do it. So actually, with discussions with myself and Sean Garside and Kath Shakespeare and other colleagues, we decided that actually to start with a pilot to test out that way of working and look at, how we get the right point of care testing in place that enables us to deliver that offer in that community setting is a good starting point. And working with Roxanna and other colleagues from an estates perspective in identifying that, and Kath's already identified, working with colleagues in ED as well, around the people that have got like 0 to 1 day admissions for varying reasons, because actually some people do need to come into hospital because we haven't got access to everything in community, x-ray, other things, but we're working on it, and it's early days. But actually I think we'll be starting with actually people that might be moving into crisis, but then actually expanding that into actually people with that frailty Rockwood score that actually are on the cusp, that we can support in a different way and wrap around. And we'll be linking voluntary services in as well, in terms of thinking about what that offer might look like in its broadest context, using primary care navigators and health and wellbeing coaches. So the vision is we're never going to have a Jean Bishop Centre in Barnsley. In actual fact, we don't need one. Actually, what we need is that model and way of working, and we can do that with some of the resources that we've already got, delivered in a slightly different way.
Well, that's really helpful reflection. And just to add in, I reached out actually to Deputy Fire Officer because I thought we've not really had much of a conversation with South Yorkshire Fire and Rescue. So I met with Andy recently, who was really interested in actually convening a conversation in the round about the opportunities that the fire service might have overall in terms of contributing to supporting some of the elderly members of our society. And I thought actually we could probably maybe anchor somehow or other the team. So he's going to really give us an updated introduction into South Yorkshire Fire and Rescue leadership team in Barnsley Place and connect us into the team, so we can just maybe weave some of that conversation through Jill and Joe.
Yeah, and just on that, fire service have delivered some echo sessions.
Yeah.
So yeah, that's really good work. So just to move on to the third strand. So this is around the malnutrition triangle. What I can say, sort of update since this presentation was circulated, is we have agreed that we will implement that alongside the Thirst for Life hydration project that was kicking off with the quality improvement team, the care homes team. So we'll do it as one project. So it won't just be malnutrition; it'll be malnutrition and hydration. So where this has come from, I guess, both when we were looking at some of the data around what treatments, outpatients, inpatient, are our frail population going to hospital for, and some of the community colleagues reflected there seems to be a clear pattern around things that are associated with poor nutrition. And if we look at the data in Barnsley, whilst it's not whilst we have quite a lot of older people where we haven't got a recent weight, so we couldn't assess their BMI. We do know there's about 10% of older people are below healthy weight. So there's a clear sort of need there. And from our community dietetics service, we've seen a threefold increase in the number of referrals over the last 10 years for older people with malnutrition. So there's clearly a sort of a growing need and a gap within our population.
I have to declare an interest in this one because some people know around the table the experiences that my mum had, not in Barnsley, I will say, in another system. And I was quite shocked at the lack of attention to nutrition, hydration, the impact that had then in terms of urinary infections and then confusion and falls. And I saw that as a complete trail through in terms of her experiences across the health system, I have to say. And then we really shared that, with as many people as I can share it with, really, including the leadership team in that particular hospital. But it was really, really interesting to observe similarly as Leslie, as you were talked about earlier on.
Big trigger to deliver.
Big trigger. So I am personally, actually, just to declare, I'm so pleased to see hydration and nutrition as part of this work. Thank you, Joe. Sorry.
No pleasure. No, it's helpful. I think the other thing to say about the malnutrition triangle and the hydration, they're both evidence-based, they've been evaluated, they are really impactful, and within South Yorkshire. So I think Rotherham have done one or more of both, and Doncaster as well. So the rollout of the hydration project is going to happen across all of South Yorkshire. We're going to do it alongside the malnutrition triangle as well. And in the slide, there's a little bit about the potential benefits from that. So not only in terms of health and social care utilisation, non-elective care particularly, but other things, diagnostics, planned care as well. There's also a reduction in the use of prescribing of oral nutritional supplements, which is quite significant in Barnsley and in care homes particularly. The fourth area is a fairly straightforward one compared to some of the others. So this is around providing structured medication reviews for high-risk older people. So for a number of years, our medicine management team have been focusing on polypharmacy and looking at opportunities to reduce polypharmacy, because we know that increases risks of falls, and they've been working their way down through the total number of medicines that a patient is currently taking. What we're doing this year is sort of actually moving the focus not necessarily to the number of medicines, but to those that have a high ACB, anticholinergic burden. So where medicines are increasing their risk significantly. And I think evidence is, if you can reduce those scores, you will significantly reduce the risk of falls, length of stay, and mortality in hospital. So there are around 500 frail patients in the group that we're looking at, and those medication reviews will be delivered by our clinical pharmacists in GP practice over the course of this year. And then the final area, which is one where we're doing a bit of further scoping, really. So anticipatory care, people will be familiar with the concept. It was originally going to be one of the 7 service specifications that primary care networks would be delivering as part of their national contract. It was one of the ones that was actually withdrawn over time, I think partly because of sort of the pressures that have been seen over the period of that contract. It was always something actually that was to be done between primary and community care, but it sort of hasn't materialised. But many areas have been getting on with it anyway, and I think there still is that bit of expectation. It's still part of the long-term plan, Aging Well programme. And some of the areas that have been doing it have been very successful in doing it. Jean Bishop, it's not just anticipatory care that they do, but that's one of the programmes that they deliver. And when they're looking at sort of different sub-cohorts within frailty, a very conservative estimate looking at the data is that they've reduced the cost associated with that patient by 10%. And that is conservative looking at the numbers. And that cohort within Barnsley is about 16,000 residents. And the intervention is pretty much based around a comprehensive geriatric assessment, but it's delivering that in community, and then looking for some of the quick wins in terms of the medication reviews, but also some of the wider support from the voluntary and community sector around loneliness, around physical activity, all those things. So that was sort of one of our commitments in the place plan. Since then, we've been doing the scoping work around rapid access clinics. So what we're going to do is sort of try and decide, assess, where there are gaps. If we have a rapid access clinic, what's the further work we want to do around anticipatory care in the community for frail patients? So that's it in a sort of nutshell. And those subsequent slides sort of give a little bit of a background, some of the objectives associated with each of the work areas, where we're up to, and our next steps. I think that it's varying between the areas, as I said, to what extent, to where we're up to. But they are all sort of being anchored within the primary community care group, which Joe is senior responsible officer for. We had the first meeting of that group. We've agreed that these are the work areas alongside others, and then setting up sort of the task and financial working groups to lead on each of these specific areas, and working towards having a firmed up plan within the sort of next month. There are a couple of slides at the end. So one around the benefits. So talked a bit about costs and talked a bit about non-electives, but clearly benefits around general health improvement. With all the risks associated with malnutrition, with falls, with polypharmacy, etc. I would expect, whilst there is a slight risk that if you're screening more to identify people at risk more, you'll increase activity. I personally think in some areas we'll see positive impact on demand pressures. For example, those needing specialist dietetic service in the future, if we can get that right initially. And then some of the risks. I think there's changes going on still within the ICB, particularly around the medicines optimization team. We are reliant a bit on Eclipse, particularly around the primary care elements and trying to assess the financial benefits elements. But that work is progressing. And I mentioned the potential risk around pulling in more people into services. And then finally, there's obviously significant interdependencies with other priority areas, which we are working through as programme leads. So we've done that work to sort of start to map out interdependencies between the emergency care, frailty, respiratory, and discharge. On that, I'll answer any questions.
You took us through that really well. Jill, did you want to come in?
Yeah, I think obviously, although we've had that initial first meeting, which took quite a bit getting off the ground, the attendance were really good, and we got apologies from some people, but we've really got a really good cross-cutting group of people from secondary care, primary care, community, voluntary sector. The bit of work I think that we've got to do is about actually that broader engagement. Adult social care are involved as well. So we feel that we've got all the key partners around the table. I think Joe's done a really good job in terms of reframing the work for us so that we can focus down on a number of key projects. Because the danger with this area of work is it grows like topsy because it's such a huge nebulous area of work in terms of thinking about, and people don't like being told the frail, but frailty in general and proactive care. We already do a lot of proactive care across the whole of the system. It's not all captured in this work programme, but I think it'll enable us to give focus, get the actual task groups re-established, set up and running, and they'll have a focus really, I think, that actually will enable us to move a bit smarter and at pace on some of the work streams, on focusing people's minds and energy around, because actually a lot of the work is being done by a similar group of people on lots of pathways. So I think we're conscious of that as well. But there's really good clinical engagement is the key thing for us. So it's not just us as leaders in the system, we've got key clinicians involved and engaged with that, driving it. So it's really good. But there are nuances around making sure that we don't double up work that we're doing in other pathways and areas of work as well.
And so it's been
Yeah.
important. Richard?
Yeah, thank you. I mean, it's really important work, isn't it? And sensible approach to it. I guess I didn't know that we had iced falls in the region. I didn't know we were doing so little in terms of prevention. There's a word in the document. It's sort of disappointing in a sense. If we had such high hospital attendances, well, not anything about it much. So this looks like the right stuff. So anxiety around lack of specificity of some of this stuff. So it said we did 900 falls assessments of primary care last year. How many are we going to do this year? What's the plan? So how many are we going to? It says that's not very many. 16,000 vulnerable people, I think you said. So quantitatively, do 2,000 this year, 5,000. So if we don't scale this quite rapidly, we won't get the benefit, and will continue to be high there. So how does primary care, community care, hospital join up properly? Because it gives a sense it hasn't been joined up. The pilot sounds sensible because you want to make sure it's right, but how long for? You know, what will be the evaluation of pilot? So is that going to be a 2-month pilot and then we rapidly scale it up? Because it feels like there's a pressing need here. We want it to be a year's pilot and then another 6 months analysing it. And then, it feels like we need to move alacrity.
Yeah, we're scoping there at a minute, Richard. Actually, we think it'll be 6 months to get the right data and intel around that, but that's the detail in terms of the next steps.
You could do it, yeah, so for our people who are advanced, they get a good service from.
There's a whole underpinning detail.
Yeah.
Yes, that you've not got here.
There is some.
We're talking about Aspire a bit, talking about where we're at with Aspire.
I don't think, well, unless you just put the data in, because Aspire is just project management.
Yeah,
So I think there's something about, Joe and I had this conversation about what metrics are we going to measure, what's the target, what's the ambition, what are the trajectories, and how are we going to keep track of that to make sure actually projects are on track, and where they're not on track, we've either got quick intervention or we decide to stop doing something because actually it's not making the difference we thought it was. So I think there is something for me about how we set those baselines, net tracks and baselines, which Joe's going to do as part of the kind of the development of the DP plan.
It's a specificity we need.
Yeah.
Well, we don't have that here, so
Yes.
last year, we either already have a number that's not in the pack, or we're going to have a number soon that we'll be able to scale up. Feels like that. So
Yeah, absolutely. I think that's a really, really helpful point. I think it was just over 1,000 in the end, age one assessments. One of the challenges is we know that frailty assessment doesn't just happen in primary care. But actually, when we look at a patient level, in terms of we don't have linked data to show the totality of what inputs happening. So that's one thing we're trying to address. So if it was done in hospital or done by Swift, we'd like to see that alongside the primary care element. But my ambition would be doing about twice as much or more this year. It's about what I've only just had back is the data from Eclipse that shows the impact of doing those assessments. You sort of need that in order to then scale the askers of primary care, but we can do that.
and we'll be looking to ultimately measure processy stuff, don't we? We can also measure outcomes. So if we're the highest place induction number with people coming to aiming calls, we can set ourselves an objective to not be.
Our ambition should be X% of the day.
Absolutely, yeah.
So we'll have the expressed in this programme.
Yeah.
Thank you.
Anything else about for Joe on that? Good job. Thanks for bringing us in. We look forward to the more detailed plan of action that will sit underneath all of St June Cook's. Okay, so we've got spider discharge. I think you were doing this one, Jamie.
Yeah. So it would have been Josh, but Josh is on leave this week, so initial and intermediate care update later. So this feels slightly different to some of the other sort of priority programs that we've picked up. So the one that we just talked about, sort of scale and some of the challenges, A&E, that front end that we had last time, and that we've got reasonably good performance in terms of discharge out of Australia. But we agree that it would be a priority looking at wider areas where we could deliver efficiencies, where we could work better together. So I'll not go through the whole overview that's set out on slide 2. But there's been work taking place through the out of hospital discharge group that Jill leads on a sort of Friday. What we're the bronze group looked at where there may be opportunities. And I'll come on to this in more detail, but opportunities to deliver some efficiencies, unblock some of the challenges that we have across a number of specific areas, and hopefully deliver then some of the efficiencies that were set out. I think we'll probably find you probably have questions in the same manner as we did for Joe around the sort of specifics and the numbers that are going to come behind this. What will it have? That's the next step. But the group had identified 12 initially priorities, and they've been sort of reviewed and then sort of slimmed down to 4 where they think there can be a bigger impact. Just in terms of scope, so there's a lot of services that link into discharges, and it says at the bottom of slide 3, intermediate care and virtual ward pathways are out of scope. We've been having a debate around this in terms of what that means in terminology, because actually, if we're looking at discharge in the round, then they can't be out of scope. But what's meant by that is there's a specific programme of work around intermediate care, there's a specific programme and an evaluation and implementation of virtual ward. What we're not suggesting through this is that we unpick all of that work and set off down a different direction. And that's where that first bit of the sort of out of scope at the top of that page, where it talks about large scale transformational change being out, unless we identify something that we thought were good that's fundamentally not, we're not suggesting a transformational change of our community, our hospital services, because generally they have flow. So the slide 3 sets out what's included. So all of the discharge pathways across D2A, etc. Discharge, and we might not call them this, but discharges or people turned around from ED. So it's not just people being discharged from an hospital admission, but from ED as an alternative, where we can make tweaks to the pathway, community bed usage, D2A, and then how we use the bronze meeting and things, or what's being called bronze. But we need to stop calling it.
We have renamed it.
We've named calling it that. It's a hospital and discharge meeting. So that's the scope of what's included. In working that up, it's been done through a discharge priorities project team. So utilising, as I said, that governance which is already there, and working through and agreeing between members of that group what the priorities should be. I guess we're presenting it here as the 4 areas for support, or otherwise, if people think there's something that we've missed or the group have missed. All partners have been involved. So in that group, we've got obviously the hospital, Right Care, Swift, BMBC, etc. The one bit from there, and I was just referencing, obviously, which is still there, Sarah, but the hospice important role. So there might be something about the hospice in this as well. But it is a sort of inclusive and work through together. So the team reviewed the ongoing challenges in the pathway, reviews data that's available, soft intelligence, understanding of what are the blockers to patient flow. And as I said, 12 priorities were identified, generate some efficiencies. 4 have now been sort of put forward as being manageable and benefits that we can try to deliver and realise within this year. Others might come forward after. Those 4 are one, and I'll come on in a bit more detail to these, but the first one is around the discharge coordinator in ED. So in a recent sort of pilot trial that's been undertaken with work in ED, which is reflected later, and that's around turning people around at the front door rather than after admission, short admissions. Links in this to the A&E work, what that model is. So there are quite a lot of interdependencies across, but that can result in then admission avoidance and where people do need to go in, potentially a shorter length of stay. Priority 2 is around clinical decision making. So this was particularly to look at and focus on the increase in temporary bed usage. And that includes where we've had inappropriate referrals for fast track, increased use of residential packages, and also increased readmission rates, which we've seen from a number of the pathways that have come through. 3 is around complex mental health and LD. We know that when we have patients with LD admitted, often the packages of care that they receive in the community are cancelled. Providers have then not got the capacity to step that back up quickly. So actually, what can we do around that to turn through? And also, as we've experienced a number of times, similar with mental health patients, where there's a need to put packages in or beds outside of hospital where hospital's not the right place. So that's the sort of clinical element. And then the 4th is around care homes. So again, the barrier to discharge, where patients are coming in and because of the lack of clarity around the sort of care and what will they need, are they coming back to us with something different, times of day and all of that sort of thing that plays through. Sometimes they've been admitted because they can't go back into the care home. So how do we pick up that work through the team? And obviously the 4 priorities, we're trying to make sure we've got the data, local intelligence to sort of play through. We know it's going to be probably a smaller number of people than some of the other things we've been talking about, but it's a small number of people that have a fairly big impact on the system. Just going through, and I'll do this relatively quickly, but the sort of 4 priorities. So the discharge resource in ED, the coordinator, work that's been undertaken was to put a coordinator in ED based on admission avoidance, home first sort of criteria, looking at people that were coming in, and some good results from that. So to 35 reviewed in ED, CDU, and some good outcomes for them. So as you can see on there, 15 were discharged directly from ED, 13 transferred to discharge unit ready for transport home, and then others. And I think the work that was done there, because I asked some of these questions around, were these people who were reviewed the ones who absolutely we felt would have ended up otherwise with an hospital admission, and they were, and so they were identified through that clinical assessment. So that's the first, and then there's a bit of a sort of follow-up pilot where adult social care are working alongside the discharge coordinator to look at where we can get some further benefits and speed things up and do things in a different way where the broader experience and sharing can support. On the clinical decision making, see that's mainly around some organisational development work around the decisions at point of discharge, making sure patients are provided with the correct care, make sure they're going to the right location. We're looking at developing a new audit process based on sort of education to support that. And Joe, you might add to some of these because you're linked in, but a system-wide approach shared by Bronze to identify the learning and take forward some of the actions, and it sets out the expected benefits there around that in terms of readmissions, outcomes for the patient, temporary bed usage, fast tracks, and there's third priority around complex and LD. So outcome is around improving the pathways, reducing length of stay in hospital. Recognise this as a current barrier, including the packages of care that I referenced being cancelled. So what the proposal is here is to create a new sort of pathway. So similar to what we have for physical health with the discharge to assess pathways, something similar for mental health, working with mental health professionals to look at how we can discharge, but make sure patients get the support that they need outside of the hospital setting, and then the ongoing care and treatment, and likewise improve admission and discharge for LD patients. So that's about working with the current care providers, working with social care and other commissioners around that. and focusing on alternatives to admission as well. So that's there with the expected benefits. And then priority 4 is around care home residents and just making sure that we can get them. So at the moment, in some cases, there's no discharge route back to usual place of residence. So how do we create an out of hours discharge pathway? Might only be to a small number of care homes that have got the ability to take the bus. So it might not always be to care home that the individual came from, but allowing that turnaround and support. Speedy assessment and discharge for care home residents. So when we know people are coming from the care home, how do we make that assessment quicker and support them back? And again, there's some expected benefits in there. Slide 10 just summarises them, and predicting, I guess, or some of the questions, and there's some that we've picked up internally and we touched on at PPDG as well, around these. So we're saying reduced admissions, reduced readmissions. Actually, if we're going to put a figure on this, we need to be thinking about what number do we expect to see. So how many less admissions, how much impact on readmissions. What we've sort of anticipated in this is that there may not be something that releases loads of cash. So I don't think we're sort of suggesting we can do something around, which other places have. So yes, we do something around discharge that means we can shift towards or do something. But what it might do is manage some of the demand in and prevent some of the spend. So actually some of the costs that are incurred by the hospital of having to manage the increased number of people that are in hospital and in hospital for longer, with surge beds and escalation and things like that. Acknowledge as well some of the, it says disbenefits, but they're not, they're potential impacts, I guess, on the system around this. Be impact on patient flow, could there be impact on the front door if we're taking longer to try and support people to come back out? Does that have an impact in terms of their stay in ED, etc.? So we'll be looking at how we track and monitor that to make sure that we understand where there's impacts and can mitigate them. And on the last page, it talks about the risk register that will be held to do that. Slide 12 just pulls out some of the interdependencies. We recognised from all of our priority pieces of work around demand management that some of the people that we're talking about will fall into a number of the groups, whether that be those attending A&E, respiratory frailty, or obviously being discharged. So we've picked that out there and draw that in. And then obviously next steps is setting up the working groups, which is sort of done and in place. We've got people working in each area of that, the risk log, to make sure we can assess any negative impact of changes that we make. And then during June, doing that detailed work to understand and model what we think the impact would be, and then what the cost saving, expense saving would be for the system. So that's that program.
Okay, that's very helpful. So any reflections on that, other than I guess the same reflection we have about the detail around actually the modelling and the impact, Jill?
Yeah, I suppose the other thing to note as well, it does link back into the South Yorkshire Discharge Group as well, this. So there's connectivity back into the broader work that we're linked in. And obviously Zoe Pierce and other colleagues are representatives of that group. So, and obviously we're briefed obviously on a weekly basis around actually what's happening in that space. We get slides. So actually there's a synergy between those two programmes of work. And I think, actually some of the areas, we did have quite a lot of debate at the group around actually the exclusions. So obviously virtual ward and intermediate care aren't excluded. But we did have a debate about the out of area patients in particular, both in terms of the patients that are out area that sit in BH and FT, but also patients that are being repatriated from other hospitals. So there's probably a little bit more work to do in that space, because my view of that was actually, although it might be on the exclusion list, we'd still be looking at those patients in that set of priorities that we've got, because I think that's really important for us that locally, because actually as a group of people on that out of hospital group, there isn't a lot that we can impact on, but we have got connections into other areas So like if it's a Wakefield patient, adult social care will support some of that narrative. We can support some of that narrative in Swift. But I think actually we probably need to monopolise on that a little bit more in terms of some of those delayed transfers of care that are truly out of area, not Barnsley residents, if you like. So there is a bit of crossover with some of that work, because I think we were a bit anxious, probably particularly Jackie Howarth and myself, around quite often the delayed transfers of care, because we get it daily, that list. They're not Barnsley people, so they're not something that I can put a service offer into to mobilise getting people out. But it's about how we use our connections a bit broader.
I certainly try through my connections with the director of adult social care to, you know, put the necessary pressure or onto those sorts of systems, really. But
it's hard, I think. Yeah, because when you look at the list, actually, it's a bit soul destroying that other areas aren't as responsive. But then I would put the question back to us: are we as responsive when we're repatriating people from Sheffield? I hope that we are, but we might not be. But we're not. We don't track them through in the same way. So I think there is somewhere, and I think the LD area in particular around delayed transfer care are very tricky, because quite often it's the care provider that actually then declines taking them back into their usual place of residence, and that's really hard. You know, they are really truly stuck in a place where they shouldn't be, really.
Sarah, we were just reflecting upon the contribution of the hospice into this area of focus as well, and working that through with the hospice.
Yeah, I mean, there is some work that I know the hospice are already doing that may impact on some of this, and it might be useful for a member of the group to speak to my colleague Ross Fletcher, because there's particularly, and I was mindful of this when Joe was talking about frailty or aging well as well, because there's a number of initiatives that the hospice are doing based on some grant funding that we got, working with the Barnsley Dementia Alliance around advanced care planning and this kind of stuff. So there is some work across both of those presentations that might be useful for this group to know about.
Well, let's just note that as an action then to take up.
Joe and Josh to link in with us.
Yeah,
I mean,
with Ross Fletcher. Yeah, just get an update from him. Yeah.
All right, thanks, Sarah. On priority 3 on complex mental health and LD discharges, there's also, we know this, there's an interdependency, isn't there, with the mental health LDA provider alliance. So I went to the last provider alliance board where obviously the propositions around health-based places of safety. We know that that's a challenge in South Yorkshire, so there's a proposition about trying to address that. Secondarily, it suggested that there's actually a bit of a South Yorkshire conversation, really. It's about understanding the efficacy of our intensive support teams, and that being able to bring that conversation together across the 4 places and talk about, you know, what's working, not working type of thing, would helpfully give us a bit of a view. Is there more to do in that space? Which I think there may well be, but let's get the conversation banked and let's work through it and see what that says. We think that there may be potentially some further investment that we need to do. Well, we know the health and space of safety will need some investment, and that needs to be worked through. So just not losing the interdependencies with the work of the alliance on priority 3, I think it's quite important. Okay, anything else from anybody? Oh, okay with this. So, caught up a bit of time, and I think we're over to yourself, Jo, aren't we, for the quality update?
Yes, it's a quick one today. Just one item for escalation, one for noting, and a highlight, really. I'll take the report as read and just draw your attention to the item for escalation, first of all, which is measles outbreak management. We've been meeting as a South Yorkshire measles outbreak group for a couple of months now. One of the recurring themes is the ability to fit the FFP3 mass in terms of the infection prevention and control, reducing the spread of infection and protecting staff and the public. It's the FFP3 issue in primary care. There is a lack of ability really to supply and fit and test and fit those masks in primary care for measles. There's a cost attached to that, quite a cost attached to it with with the training and the supply of them. Currently across South Yorkshire this is mirrored, so we're not unique in Barnsley in that. The group's been meeting and discussing this, and we've had our medical director David Crichton in one of our meetings and discussed that at some length. I was asked to put an options appraisal together, which I have. There are 3 options, which is basically buy a service from the Acute Federation in South Yorkshire, stay as we are. The information from our South Yorkshire virologist is that we could use masks and visors, surgical masks and visors, double up basically masks and use a visor, which is currently what we're using. And the other option is to look at fit testing, paying for fit testing, train the trainers in our primary care, and also supply of the masks through to our primary care organisations. Again, that appraisal shows that there's a cost attached to that and some supply difficulties potentially. So the options appraisal paper is going to go into our Director of Nursing for Patient Safety and IPC now for a decision as to whether it goes to our operational executive group and is added to our corporate risk register, and for the board to consider, for our OPEXEC group to consider the options and which is the best option really. But in the meantime, I think there's an ask at place until that's resolved. If we could add that to our risk register at place, because it is still against the UK Health Standards Agency advice and guidance, and that's written advice and guidance, and they are not moving on that guidance. So that's just to really flag that and let the group know what's happening in terms of mitigations in the meantime.
Okay, thanks, Jo.
Okay,
Any reflection? Yeah, any updates, any reflections on that from anybody? Yeah, we can take Paige, anything in terms of the risk register? Ask.
It can be added. There's a place. Is it to the place one out of South Yorkshire?
It's a South Yorkshire. It's a South Yorkshire risk, isn't it? Then you say
it is, but it's to add to our place risk register as well, because the other places might have some slightly different mitigations, so it'll be a nuanced entry onto our risk register, but the risk as such is the same. Yeah.
To be honest, I think it needs to be reflected on the South Yorkshire.
It's
risk
going.
register.
Yeah, the ask is there, Wendy, for it to go on that one. Yeah.
Right.
Definitely.
It's a bit confusing about things that happen at South Yorkshire, on a South Yorkshire risk register, opposed to things that are very specifically just about Barnsley. So I would say it's South Yorkshire.
Okay. No problem. And for noting
just 2 minutes, Jo.
Oh, sorry.
Just 2 minutes. Are you rattling through?
I know.
It's interesting because part of our chair, the health and safety committee at the trust, and you must have come across this. It's the ability to show, but by individual, that each individual are fit mass tested on 2 different
trained and tested on 2 different
to do it.
times.
So the main issue is that people, fit mass tested full stop, and can, because of everything that's happened. So we are had access. We've had people from the fire service. I've had mates who work in industry, that licensed people that have helped us as mutual aid during harder times. That all that's gone now. So we're having to sort it out ourselves. So from a local perspective, Jo, Christine Fletcher's Fisher doing it now. Our IPC lead obviously works, supports place as well as just looking at that issue. We've got a proposal coming to our exec team. So if there's anything that we can do at a local level that makes sense, that would be great for us, because it's all extra cost. So we're trying to just think through similar sort of options really, but it'd probably be good to get access to someone locally.
Yeah, thanks, Bob. Christine is now part of our IPC, South Yorkshire wide IPC group. She's invited to that group. She'll come in and out when she needs to come, but on the measles, we're keeping a really close dialogue as well. So thank you.
What's your role or eyeballs when you mention it?
Richard.
Yeah, I was slightly surprised to hear the Acute Federation as an option. I don't know anything about that. What's the Acute Federation got to offer?
I think there's a recognition, Richard, that our acute trusts have pretty much got the FFP3 testing supply capability is what we've discussed at the measles group. If that's different, forgive me, but that's the current state that we've been told. And it was really just to explore whether a contracting arrangement would be something that could be discussed given the financial position of South Yorkshire ICB at the moment. But that was the conversation.
Okay, thank you.
Yeah, bit of a line of inquiry almost, really.
Yeah.
Okay. Thank you. Anything else you want to raise? There was something there about the LGA, Health Action Plans and Health Passports.
It was raised at the previous month's learning disability and autism learning disability deliveries group, and then we were asked to raise it at QSC, our Quality and Safety Committee, which we did, and it was around the varying quality of health action plans and the completion of health passports across the patch. So Emma White raised that issue, and I know that she's doing some work with partners in that who are working together in that. And then there was a little bit of a curveball as well, just around the same time thrown in from NHS England after a lot of engagement and consultation had been done with our public in Barnsley around the health action plans and health passports. In the NHS England were looking to introduce one that was kind of a shortened version, but not an easy read. And there was some discussion about whether that would be imposed and the impact that would have. Following the work that's been done with members of the public and people with lived experience in Barnsley. So again, that's sitting with the LDDG, but I was asked to note that at QSC and here.
I'm sure through the LD group they would make a sensible decision that makes sense for Barnsley people.
Yeah.
From my perspective, Sheena.
Can I just ask about something else?
Oh, yeah.
All right. So on the intermediate care, I know we've got a conversation about it, private, but it says that there's a concern about the ongoing provision and impact on wider services, potentially increasing costs. I just wanted to understand that a little bit more, really, if I could, Jo.
I think that's around. My understanding is that's around the current arrangement where there are 24 beds in Ward 12 and 26 spot purchase beds, and ongoing looking at a 50-bed model. New build model. So that was around the model and what that possibly would mean in terms of cost pressures in spot purchases in the meantime.
For the long-term solution.
The unclarity, yeah. Is the 50 beds, is there going to be a 50-bedded unit or is it a smaller bed unit with, it's not clear yet, is there going to be a smaller bedded unit with some spot purchases? So again, I think it's as that will emerge, there'll be more assurance.
I think in terms of the definition of the risks in the context of quality, I would say is really important, Jo. So when this report comes through, it'd be really helpful to be really clear about what the quality impacts then that you're observing around the work around intermediate care as they are reflected in here. Because sometimes we can all, we've seen, haven't we, Leslie, broad statements about risks in quality reports, when actually we want an observation about what's the quality dynamic that we wanted to identify in amongst this. So it's just a point of reflection, Jo. That's all in terms of the future reports.
I think we've clarified that on the QSC report, but shortened it for this. So I'll note that and we'll put that right going forward. Thank you for that feedback.
Lovely. Yeah, well, that's thank you, Jo. Anything else from?
I think it's just following on from that point that you raised, Wendy, just a bit on the flip side of it about the mitigations. So Jamie's just mentioned that this may well not be up to date, but it's saying that obviously it's not an ideal situation with intermediate care, but risks and mitigations are managed at QSC. But I think it's probably managed here, isn't it? And certainly at our board as well. And I'm sure, Swift are having conversations about the impact as well. So just to be clear again, I think, it's in the public domain, isn't it? So we need to be accurate.
We should ask for an amendment there. Yeah, that should be amended really, Jo, because it is here that we're managing the risk. Thank you, Sheena.
We'll amend that. Thank you.
Helpful. Thank you, Jo. Okay, we've got item 14, which is the terms of reference. Get them open. So, just to note that 360 Assurance undertook an audit of all of the place governance arrangements, resulted in a composite report. Actually, to be honest, when I looked at the findings, I thought actually Barnsley did pretty well. We had a few actions I think that we've noted, and they're noted in this particular report as well. As you can see in terms of the bullet points in the covering note. So I would just suggest that we have a quick look actually at the terms of reference. Because I think the actions as they noted in red are actually reflected in the updated draft. And I've observed a couple this morning that I just wanted to talk to you about. So I'm in the combined PDF pack, by the way, for this when I mentioned the page numbers on page 83 of the combined pack, but it's 6 on the terms of reference where it talks about membership. What I'm proposing in terms of the membership is that we add Jamie as a deputy place director in terms of membership for the place committee. Anybody objects to that, please do say that now.
I'd support that because I think the issue about quoracy is not actually adding number of members. It's the fact that both you and I have got to be here, and that's what affected quoracy last year. And you inevitably, something's going to happen. So I think it'd be really good if Jamie's a deputy for you.
So we can add Jamie, if that's all right. Yeah. Okay. Thank you. And then we also had another observation as well.
It's the next, it's under section 7 when did a bit about the other membership.
I jumped past it. Oh yeah, participants, that's right. Number 7 talks about participants, and we of course have got Barnsley Healthcare Federation Chief Exec and the chair there, but then it refers to Barnsley PCN, chair or chief exec.
Yeah, so I think it's just not accurate because actually there's a chair and chief exec of Barnsley Healthcare Federation as partners around the table, and that's who should be members of the place partnership. And then if we wanted to include PCN as the accountable clinical director, which happens to be same as BHF chair, but that wouldn't necessarily have to be the case. It could be 2 different things.
Yeah.
Do we want both represented or a BHF representative? Urban's had to drop off, hasn't it? So, but it should be chair and chief exec of BHF.
And then accountable clinical director
for the PCN.
For the PCN.
Yeah, because at some point they might be different. It just happens that they're the same person at the minute.
Exactly. Yeah. So I think we should keep that.
Yeah.
As proposed, unless somebody thinks any different. Yeah. Okay, so other than that, I think they are the main really perspectives.
Roxanna was the second.
Oh, go on, somebody, who's going now? Who's going?
There's no numbers in person, is there?
Little flags.
It was just on the quorum point. So we also want to recommend that the meeting is quorum with at least 3 members of the meeting present, including one of Wendy, Leslie, or Jamie.
Thank you. I got that note as well.
Yeah,
I think it needs to be 1.
We would also recommend that the frequency in section 12 is amended to say that we will meet at least 6 times a year to allow us to have some development time if required, which means we then don't have to have a business meeting every month. So we would ask, we're asking that that's also supported, just to allow us a bit of flexibility in our agendas.
Oh, thank you, keeping us on track, Roxanna. Any objection to that summary? Yep, noted.
Yeah, just a reflections on something. So we talk this as our partnership board, but the ICB calls it a place committee, and I don't know if that is a meaningful difference, but a board sounds like a bigger thing. Also, again, this is a bit philosophical in sense. Partnership board, but the only people with votes are ICB officers. In what sense is it a partnership board? So for our board in the foundation trust, I'm sure it's Swift. For the board members, and we'll have attendees. The members have a vote, and we don't have participants. We have members or attendees. Here we have members or participants, but the participants don't have any decision-making rights according to this. So I'm just pulling that out.
Yeah, no, that's right.
So,
that is, yeah.
So we can say stuff. But the 5 or 6 of you, ignore it. I'm used to it already, obviously.
There are two different things. So, so there's in every place, there's a subcommittee of the ICB board, which is the place committee, which were initially set up with the same members, which were the membership that we'd got. And then we've got separately our place partnerships. So what we've not got here is the place partnership terms of reference, which we might want to have a look at and bring in. So it is different, isn't it? Because this is the specific board of subcommittee of the ICB.
Some of it comes down to the review of the scheme of reservation and delegation. I have to honestly say more broadly across the ICB, but I won't say any more about that for a minute. You're itching to come in. Come on,
Just because so this is the subcommittee of the ICB in terms of effectively the senior leadership team for Barnsley Place that's employed through the ICB. It's the decision making forum for that. The ICB chose when it was set up to have these two separate things. That actually, if we were in true partnership with true delegation, you wouldn't have the two separate things. You would have one business meeting whereby all partners were making decisions around the resource and service delivery that comes into Barnsley. But because of the scheme of reservation and delegation, that's not currently allowed, and the decision making still has to be within the ICB element. So any funding decisions, any service change decisions from a commissioner perspective in the old world language are still separate. So unfortunately, we operate in that we have one meeting. That's one meeting. We don't separate the agendas. We bring everything here actually. So despite the fact we're going to have two sets of terms of reference, because next month we'll bring the partnership terms of reference along with our whole partnership governance. But we do actually bring everything here because actually the value of gaining partner input into any decision is still valued. So I think it doesn't answer your question, Richard, but I suppose what I'm saying is, unfortunately, because of how the ICB is constituted, that's why we've set up these two separate.
There is probably though, isn't there? Because I recollect being in the executive when we had a conversation about actually having a look at the scheme of reservation and delegation. So there may well be something to just take back to the ICB exec, and maybe actually indeed to the development session, Leslie.
And
actually, where are we at with taking stock around the scheme of reservation delegation?
Yeah, because I was going to make the same point that Jamie and Roxana have made, they were the antecedents of how things are set up. And I believe I'm right in saying some places have opted to have two separate meetings conjoined. So they have the place committee and then they have the partnership board, and this is different. But I guess in the spirit of doing the review of governance of what is still a relatively new organisation, and we've been doing a lot of reflection, haven't we, just recently about governance. I just wonder whether it's worth going back round that loop again and saying, it is now we've got the 2 and a bit years of experience. How does that feel, and should it be the same or should it be different?
That's one of those subjects that's a really helpful thing to land an SLE, isn't it? Have a really big discussion about that sort of stuff.
I was reflecting and being advanced a little while now.
Sorry,
we've had various iterations or incarnations of partnership meetings where we've had the key big organisations, particularly who came together, and we had sort of two members each, and we had votes. So we all had a sort of say. Now we can make points, but we haven't got a forum like that anymore, which maybe that's just how the world is. It's changed, but that doesn't feel quite right, because you've got your statutory duties in ICB in your officer roles. The rest of us have got our statutory duties to our organisations, but that it doesn't quite feel right, because you also presumably have your meeting separately. Your business. Your people. So not all your decisions presumably come through here. The decisions you make.
No, so they all come through.
They are clear to
We do a report here around any decisions that are taken. So it's a report, but only to
that tells this board the decisions you've made.
Yes.
It's just understanding what the purpose of us being here is. Because
it's a really helpful reflection. I'm with Leslie. I think it's time to just take a bit of a breath on it personally.
Yeah, I think it kind of. My point was really probably about the partnership terms of reference that are coming in, but I think you know, there is an opportunity to pause and reflect, isn't there, and look at what's working and actually what's the spirit of what the place wants to see happen as well, really. And so, you know, we don't have to wait for the ICB to decide things. We can suggest things as well, can't we? So, and, you know, I think the other part of that is at place, you know, what's the role of health and wellbeing boards compared to here? And the same for actually probably potentially 2030. You know, although I guess it's more of an argument for that being separate, but certainly health and wellbeing boards, and certainly in other places they've brought the two together because the same conversations are happening in two different places, and that doesn't seem to make sense either, really. And actually, one of our roles, all of us, is to make sure that governance doesn't get in the way of doing stuff, really. And you know, that's really important, that we consider the streamlining of that and everyone's time, you know, and the resource that goes into all of that. So if we're going to have that review and that pause and reflect, why don't we just look at the whole bit of that in that relation as well?
So yes, I'd agree. Time to do that, isn't it? To take stock. We also need to, I guess, face into the fact that our health and care plan, as it stands, is dated to
end of this year.
End of this year, end of this year. So it's probably time for us to have that taking stock sort of conversation, maybe, and bring the whole two bits of that jigsaw together. Yes, we think about that to the whole plan. Take time all together. Yeah, so we'll take a note of action then, that we need to put that again. We've got a few things on the phone. Sorry,
since I've started here, I've tried to figure out how things work, and I just whispered to Bob, I thought I was being thick. But actually, this conversation has really helped me understand why I don't understand it. So thank you for that. So I think there's a number of things around collaborate. You know, the point of collaboration and partnership is around principal subsidiarity and the right decision being made at the right place. I've not been able to understand that. Now I understand why. So there's some pushback on that, because we've got a statutory duty to collaborate, but if we're not able to then make decisions within that, then you can't really discharge that duty either. And there's examples elsewhere in the country where they've nailed this better, actually. I'd be so bold as to say. So I think there is something about you've got to delegate to enable, to empower others to take responsibility and ownership. And I think something pushback on that is very legitimate. Otherwise, we're not following the spirit nor the letter of the focus on partnership and collaboration.
Yes, I would agree. I'd agree, and I think basically on Roxanna's reflection, this is just the way. This is the way in which the ICB has chosen to set things up around here. But nevertheless, we have been going for a couple of years now, distracted with the RCA and all the rest of it. You know, 2024 is probably the year to take a bit of a breath.
To get the leverage from partnership, you've got to do it properly.
Donna, are you able to share where I've done it and done it well?
Yeah, that would be helpful.
I think one of the things when we go back and have the conversation with our governance colleagues will be the time it will then take to take us through. Whereas actually, if we've got what good looks like already, we can give them something that's ready-made to look at. I think that's probably got more chance when the being had been taken forward, as opposed to somebody starting again from scratch.
Let's do that then. Thanks, Dawn. Okay, so we'll make some of the amendments as they are noted in the covering paper, and circulate a revised set of terms of reference whilst we plan for a more substantive conversation in due course. Paige.
Thank you. Right, so I've got the report here for assurance, and I'm going to take the report as read, but I've just got a couple of things to note for information. So Barnsley S&T have conducted a quarterly deep dive of the risk register and issues log at their meeting on the 16th of May, quite recently. So for information, the BAF risk register and the issues log has transferred to the new digital system, which was launched on the 1st of April. We're still running with the Excel registers as well, because I think they're having a few problems with them as well. So people that do not work for the ICB cannot access the link to the live system. So I think, so apologies, in the cover paper there is a link that you'll not be able to access. Yeah. So also for information, they're working on the new BAF, which has been brought in line with the South Yorkshire 5-year joint forward plan.
and that went live on the 1st of April as well. So I'm happy to take any questions. Please.
It's still settling, isn't it? I think that'd be fair to say it's still settling. I mean, even in terms of the sort of cover report, really, there are some risks that talk about Barnsley risks. Actually, some of those are broader South Yorkshire risks, of which Barnsley might have a bit of a stake in it. So it's not quite settling in the way. So I know there's more work to be done on it. Jamie, did you want to come in?
Yeah, I know, Richard, you've got your hand up as well. So, but I guess, and because I've look through this, and I think there's a corporate risk rate. So this is an interesting one, Richard, in the context of place committee of the ICB, and us being asked to consider risks that impact on Barnsley Place with our partners, as opposed to what we've identified as our place partnership risks. When I went through this, Wendy and I were having a conversation earlier around some of the things are broader risks that might actually be fundamentally about another area. So some of the things in here are specifically about Yaz, some of the things are specifically about Sheffield Trust, but might have an impact on our patients. So because there's a reference somewhere in the line that it's all places that it impacts, it comes. So part of the feedback I think that we would want to share is there needs to be something that separates out where something being flagged to us that somebody elsewhere is trying to mitigate a risk. We need to be aware of the actions and possibly contribute. There are others that might have been escalated from our partnership that are on the board where actually we, either as a place team of the ICB or partnership, are specifically doing something about it. It feels weird having red risks on here that we're potentially not then taking away as a committee any specific actions to address. So there's a number that work through. So that's why they're all on there. And I've got some specific elements which I'll just pass back page to you that I'll do on reading through.
We did feedback as well, no, Richie. We did, for example, SY 119 about CEDAW. Well, that's a broader financial, should be clustered into a broader financial efficiency or a financial challenge sort of risk, shouldn't it? For South Yorkshire, of which there's a revenue risk and there's a capital risk. So it's a bit curious how I think it's crafted today. So it's not quite right, Richard.
Yeah, I kind of feel like nothing much has changed in the last 6 months. The comments I'm about to make, I've made twice before about the same risk where the words haven't changed at all. I'm a bit confused, and it may just be the way the papers are shown up in the way that's been put into my pack. But there's just these massive spreadsheets that you can't. You can sort of zoom into them, but I would challenge anyone to really understand the aggregate risks across the system if that's the way it's presented. But there's one particular one, SY001, which I flagged before here on 2 occasions. It says if PHNFT/DBHFT did not improve performance with respect to people waiting longer than 60 days, blah, 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 for cancer. Barnsley has the best cancer performance of any of the hospital trusts in South Yorkshire. I flagged this before. It's not been updated since 23.
I thought it had been taken off, Richard, so.
Well, yeah, my fact.
Yeah, I'm not looking at the spreadsheet at the minute, but I thought we'd asked for it to be removed.
We have.
Yeah, it's here. It's the public document today. I think it's an exception.
Has it gone off the last one?
Probably like a minute to express that. It's not correct. Description of the current Barnsley cancer performance.
Let's make sure we get that absolutely recorded in the minutes. Let's pick up a conversation with Ruth and Mark Jambier about how this, well, it's not the what and how this is presented into the place committees. Because it's again, I think we've had this conversation a number of times really now. And we need to get it right. So I think personally, I would say that I wouldn't want any paper, so I want Leanne, I want any risk paper from the back paper coming into table into this committee without us having had a really thorough examination of it in terms of its accuracy or content. And we just need to take an action on that collectively, I think. Paige, you can feed that back to Ruth.
On that one previously, discussion had been, and it had been wrapped up in. So there's one in the cover paper that's referenced, which is SY115, which is more broadly around operational recovery in relation to cancer services. It doesn't specify then that that's an issue with Barnsley. It's the overall stuff, and it's the work of the alliance, and that's appropriate. But the other one shouldn't be there, so I've not seen that.
I think when it came, it was like 300 and some odd pages.
Yeah,
And
it's
to
not
sit
very
and
nice,
mess with that to get it to fit. Yeah, I think we're just all over the place.
Yeah, I had it on a big desktop, and even then,
Yeah, you couldn't still
doing
emphasise these.
It's a risk, I think it should have.
War and peace.
Yeah. Register.
Yeah.
Okay, well, we've noticed some actions there. Thank you for the feedback. We need to get this right because it's been a bit of a long journey, I think. But appreciate, Paige, you're here to deliver the paper for us today. Thank you for doing that. The Barnsley. Yeah, Barnsley Place. Let's register, Roxana.
Yeah, so this is the partnership risk log and register. So there is a summary sheet. So just to note, there are no new risks. The FROs for each risk have been asked to sign off the updates, which are in the pack. All the updates are included in the majority of the risks, not all, because I did get one that wasn't updated, but are in red text, so you should be able to see what the updates are. I will apologise because the summary table, for some reason, is on the intermediate care risk, it's picked up some random cell, but that risk score has been increased, and that's linked to intermediate care and the short medium term solution. So that risk score has been increased by 7, and that's due to the increase in spot purchase capacity and the risk around the costings for the interim model, because we've still not had the costings for the interim model. So that's why that risk score has been updated. So I will reshare the summary slide just so everybody's got an updated, and make sure it gets updated in the public pack, but just to note that. Everything else in the slides that have been included are there for update, they're there for comment, and for any further mitigations that the partnership feel that we ought to be reflecting through the risks in terms of risk management. But as I say, they have all been approved by each SRO of the risks that are included.
Okay, thank you. Richard?
Yeah, I think it's really nice. It's really clear, really laid out, and just to show what it should look like. So this is a really good example of perhaps the ICB could learn from Barnsley. Just one call out. What about health inequalities? I mean, I don't think it's just a philosophical point. I think that's not really a risk; it's an issue. So I guess health inequalities are a factor in Barnsley, rather than. But I wonder if it's about how we describe that. So I think the risk is probably more about the cost of health inequality in Barnsley. We need to make sure our services are designed appropriately, so the consequences of that aren't, disproportionately bad. Something like that.
Yeah.
So it's perhaps how we articulate it rather than health inequalities are a fact.
Yeah.
How we deal with that is good or bad is the risk.
Yeah.
I think.
Okay, I'll pick that up with Anna.
That's helpful. It's really clear. Any other reflections on that? It's a living, breathing document. So as our work continues and the projects and the areas of focus develop, we'll populate that together. And I suppose PPD's got a key role in helping us with that. Okay, thank you for that. As I've said, item 17, we've transitioned the item to the private session. So we're on to item 18, performance. Let's do the annual review as well. So.
Yeah, and I just finishing on this. That off. Yeah, that's my water. Yeah, so from a performance perspective, I think just before I start the paper, I'll just pick up the point that I referenced earlier. So since we've got Sarah into post as the new director for performance in the ICB, she's been reviewing all of the arrangements, and that includes the sort of performance framework, the reporting that goes into the ICB board, around some of the sort of national measures, the things that we have to do, but also then what needs to be the responsibility, accountability at place, and where we would want to focus. And included within that place, the start of our conversations is how we broaden out just from ICB responsibilities, given we're considering some of this paperwork in a partnership context to cover some of the elements around social care and other things. So that's early. So what we've got is still very much focused on the traditional reporting that covers off NHS providers and predominantly around health. So you've got, as the appendices, the overall performance report for the ICB. Acknowledge that's a little bit day in terms of timing, so some of that relates back to February. And then Appendix A is a sort of shorter report that picks out some of the specific measures from within there for Barnsley. It still looks relatively red, and that's something that I've picked up in respect that it's red because we're being measured in this against what are the constitution standards. Actually, from a planning perspective and from an NHS England objectives perspective, we're not expected to be there. So if we're showing as red against 95% performance, when we're actually asked to get to 78% by the end of this year, so I think that needs reflecting.
Yes.
So I think we'll look at doing that, and that needs to be included in the future one. Just in terms of what we have got though, from an urgent care perspective, so there's a lot of focus at the South Yorkshire Alliance on this, which Richard, you chair, don't you, and making sure that each of the place plans are focused on the sort of right areas to address, particularly it in the 76%, helping to address ambulance handovers and the other areas. Performance that's shown in here is just those sort of 70%. That's April, so a little bit of a dip. We saw an improvement in March, and as a result of that, we're recognised as one of the top 10 improving in that month, which came with a bit of a prize, didn't it? So there was some additional funding, capital funding that comes with that, which you need to, obviously you'll be working through how that's utilised, but that's as a result of, I think, lots of hard work, but I think a lot of pressure on everybody across the system, and particularly in the trust. And I think it's long term probably not a sustainable way to be doing things, is it? But did lead to that improvement. And currently, performance has picked back up again, hasn't it? So whilst they saw that dip, it's coinciding actually with an increase in attendances and other things. It's sort of settled down, and this last week or so, it's been pretty good, hasn't it, from an urgent care perspective?
In the 80s this week.
Yeah. That's generally good. YAS response times in April reduced, so that's an improvement. And category 1 calls are being met. There's still pressure in there to go further. I think from an elective perspective, picking up, within this paper, there's reference to both Barnsley people and whether they're at different hospitals and Barnsley hospital performance. So overall, we have still got some waiters at 65 weeks and over 78 weeks from a Barnsley perspective. But actually, Barnsley hospital haven't got 78 weeks, small number at 65, and in a good position, and comparing really well across both South Yorkshire and wider than that. So I think we're in a decent place on that, but we have seen some slight increases in the overall waiting list. Diagnostics performance, again, Barnsley hospital position is better than our overall position. So for Barnsley Place, 91% of people are seen within 6 weeks. Barnsley Hospital has been above 95%, which is the expectation consistently. In March, it did. So we've only got March's data for this, but it did just dip a little bit on the back of some of the challenges that we've seen, and obviously industrial action and other things all has impact. But diagnostics really good and ties into the planning. From a cancer perspective, they're achieving the 28-day faster diagnosis standard and have been consistently now for a while. There's still challenges around 62-day and 31-day standards, which are the 3 now that we utilise in terms of measuring performance there. But we are continuing to see, and there are there are relationships to other providers there as well. It's not all within our control. And then mental health, we've included on there, which picks up the talking therapies that we referenced earlier. We haven't seen improvement, but slight dip, so we saw less people in February, March than we had at the back end of last calendar year. Not sure why that is, but that impacts then on the achievement of the trajectory. The other bits are broadly there. I think the other part that I would pick up, and we'll see where this goes. It's not from in our, but it is in our report, and it's also in the other, but we're not included in the narrative. We're just around the primary care aspects. So we've been reporting ongoing sort of increases in same day appointments, numbers that were getting their appointment in 1 week, and in March it actually dipped a little bit. So I don't know what the reasoning is behind that, and we'll see whether it's a one-off. It's followed a pattern, but there was a slight dip. We still compare reasonably well with others, but yeah, the percentage that were given an appointment within 2 weeks, that same day, did drop a little. So they were the only things that I wanted to flag to us from there.
Jeremy? Richard?
Just on the workforce section, I think we've only got data on Barnsley Hospital in the workforce section. So just why that is.
Is that in the appendix?
Yeah. In the big table of reds and greens.
Oh, now there's. We haven't got Barnsley's data in there.
We've just got
Barnsley
Barnsley
Hospital.
Yeah, and they're in it.
Oh yeah. Yeah.
Yeah, 5.5%. Yes, yeah.
Unless that is because the only reporting of workforce figures that goes through will be Barnsley Hospital. Because Swift's reporting a workforce in West Yorkshire.
But we'd be interested in Swift's services because
it's
just where it comes from.
It's just where it flows into here.
It's been raised as part of the IPR report overall, and where sometimes you do see slides and presentations where Swift is absent, and we have to keep persisting and saying, no, we do need to have Swift's data, as well as we need to get to the point where we get primary care's data to really be able to have a composite, trusted set of information here in this dashboard. So we do need to keep. Can you take that one back?
Yeah,
So
feed it into the report because
there's no reason, is there?
No.
That can't take that out.
Because it was the same when we talked about community waiting lists.
Yeah, absolutely.
Services not reflected, and
yeah, we've got the UCR data in. UCR data in.
Yeah, it's what we've set up local floors to get.
Yeah.
I mean, that's really positive, Jill, as well, isn't it?
Yeah, it is. Yeah.
But, yeah, I think that up as a
that's
start with Sarah.
Okay, thank you. Anything else from everyone? Yep. Okay. So on the annual review.
Oh, sorry. Yeah, so I mean, most people, but not everybody, including me, actually. So I'm doing it, but I won't. Attended the annual review meeting. So this is, we've previously had sort of quarterly reviews. Before we became an ICB, they were NHS England's sort of way of providing some of the assurance, and we came together as a partnership and talked through slightly different approach. And I think again, it's something that Sarah wants to have a look at. What's the purpose of them sessions? How do they play through? But we tried to provide a sort of balanced picture of Barnsley and where we were doing well, but where some of our challenges were. So the slides are there just for information for people that weren't in attendance at the meeting, and talk through a number of the key areas that actually we've probably just reflected in the performance report, but bring out some of the good things, and they might be useful for people just to talk on if they're using it as information.
And the key for me is that sort of consolidation between the 4 place reviews, annual reviews, and then actually there must be some themes that emerge from that, relationships and improvement work and that.
And it'd be interesting to see linking back to that conversation before about delegation and whether there's any themes coming from.
Exactly.
In terms of
Or indeed best practice as well. But best practice that people could adopt. So there's definitely a journey to be had on. on that. Bob?
Yeah, just one bit of feedback. I taking the spirit of even better if it's a reflection really. I think I'm saying this because there's so many metrics attached to the hospital, it's unreal. We're going to discuss this quite a lot. But certainly I think when we're trying to put these slides together and project out what we're trying to achieve, I think we're getting better, but it still feels quite segmented, was my reflection. Listening, there was nothing I was going to say obviously at the meeting, because you want to project Team Barnsley, be honest about your issues. So when we talk about mental, say primary care, we'll be talking about dentistry and optometry, and not just what the GP Federation is doing. When, you know, I think some of the stuff on autism, we didn't really pick up on you know, the service swift to the pathways, brilliant, you know, with this issues around that. You know, I think, and I'm walking the walk on it, because I put quite a bit of effort into the urgent care thing. I didn't present it as ED and what the hospital's doing, the group. So I thought about, you know, what the whole urgent care offer as an example, if you like. So I am walking the walk, but I think it's just an even better if, and there's a bit of repeating in it as well. But I do like the bit we're putting forward what we want to do, you know. So it's just some thoughts since the meeting, really.
No, it's really helpful, because it's only together by reflecting on it, can we get better actually the next time round. There'll be the quarterly, so the quarterly check-in, so we can take stock on the approach for next in readiness for the next one.
And linked to that, do we get feedback? Is there an expectation of?
I haven't seen anything yet. We used to get a note of the meeting and outcome, but I've not seen anything back. But I don't know who we're looking at to do that, because
Sarah, to be fair, it was in the early days of Sarah's. Just
anybody there from an administrative perspective, from Sarah's team to
no.
So they might have, maybe one for learning, they might have been looking us to capture the meeting and the points, and we might have been looking to them.
Marking our own homework.
Yeah.
There's a bit.
The Katie sitting on it.
It used to be us though.
No. So if Katie were there, Katie may have, and Katie's been off, hasn't she?
Let's take that away and then pick up a conversation with Sarah too, about, because actually they've all four have happened. So even there should just be a consolidation, shouldn't there? The headlines, reflections about working well, challenged by, work to be done. Just mean that sort of thing, really. You pick that one up with Sarah?
Yeah.
Thank you. Okay, so we've got a cluster of things there, she says. Item 20.1 to 20.4, not planning to go through all of those individually. If we could just take those as updates, and if somebody's got any points of observation from those. And item 21, updates and any escalations from partners. A couple of things that we'll take on the private agenda a bit later on as AOBs. Nothing.
The only bit I guess to feed in is just that discussion around committee partnership delegation. It's worth referencing it from the partnership as opposed to just that.
Yes, that's a good point actually. Yes, do that.
It's how it all fits together with those review meetings, the outcome, the expectations, what we can do, and all the clarity, I guess, around that.
It's helpful. Anything else anybody wants to raise? Any AOBs? I did actually have an AOB, Wendy. It might be something that you could help. I mentioned it to Jamie yesterday. Following the workshop that we had with the Health and Wellbeing Board, were there any notes from that or any update from the workshop? Were there any workshop outputs?
No, it was just said how good it were and how helpful it were. There was no.
I asked Cheryl. So there's not been anything circulated.
Right.
But the intention is to talk through it at the next meeting, which is next week.
Could be next week.
It's next week. It's on the 6th.
Yeah.
It's next Thursday. So they're going to cover it on the agenda and talk. So I don't know why there isn't a note or item from it.
Right.
We're talking through it.
Just a nice frustration. We just talk Quick reflection on how well the meeting's been conducted. Any particular points of observation at all?
I feel like we've covered loads of ground today.
Exhausted.
And different, different topics.
Been a lot of ground covered. Richard?
Yeah, it comes back to the earlier discussion about the purpose of the meeting, aren't it? So a lot of people in the room, a lot of cost. We talked about a lot of stuff. Have we made any decisions? Change anything today? Is this meeting about making decisions or change things? I don't know. Comes back to bit to our purpose and in terms of reference. We observe stuff, we talk about it. Next month we'll do the same thing again. So what's our purpose in terms of what being here together?
Maybe that is the conversation we said this schedule that we'll have.
Yeah. I would just say it probably steps us back a little bit further than the terms. So not the place committee ones. They are as they are, but as a place partnership, we've got our terms of reference that are coming. Actually, we've got our all place partnership agreement. And when we were developing that, the intention was that actually there would be business that came and would be made decisions, partners would be able to operate in a different sort of role from their organisational role decisions. And I know that didn't get to where it is, but so there's perhaps a need as part of the work to look at the all partnership agreement in terms of what are we coming to do, where are the areas. Some of the stuff we've talked about frailty, there's might be things that we do, but a bit more meaty. So
there is just something. There is something about the space that we.
Some of the ICB business.
Yeah, well, exactly. Yeah, the space that we uniquely occupy to deliver what value, as opposed to the space that the Health and Wellbeing. I'm still having in this quandary the unique space that the Health and Wellbeing Board occupies to deliver what value, or to 2030 to deliver what value. And I think there is something about that whole schematic of improvement, development, effort, and energy, and about just having a really rich conversation around the whole lot. Personally, but that's how I feel at the minute, if I'm being absolutely frank. And I think that would be a good thing to do. Oh, go on.
Yeah, no. So I agree with what Richard's saying, and I think people tell by people's reactions, people enjoying a bit of a push there. I would just counteract that a little bit in saying what I felt when I read the papers and listening to everything today. You felt like we've had the full suite of everything. You paced yourself well, it's been managed well. Feel like colleagues have been reflective about what's going on. So as I've heard some of this stuff before, so it's been a bit slow at times, but that's not, that's my issue, not anyone else's. Do you know what I mean? And I think it's allowed us to. There's been some good interactions and some good listening going as well. I think that it's easy when you're, say an NFT or a well-established organisation where the drills are understood, you might change them, you might improve and all the rest of it. I feel like it's not for me. It's not entirely clear direction being set either nationally or in the wider. At times, it's like you try to find the right way, but there's that desire for more in Barnsley, which is really good. So I won't beat yourself up. Specifically, I think it's a healthy conversation about Health and Wellbeing Board as well, because clearly it's not a takeover or whatever, but there is something about the nuts and bolts of health and care that we're pulling together in here that you probably wouldn't rehearse all that in front of the police or the fire service or house. Like there is the Health and Wellbeing Board is occupying a space that is about the wider determinants. So I get what people are saying. For me, Barnsley 2030, but it's 25% about health. We think health's, but it's the business, sustainability, learning. They're huge agendas. There's a really wide, broad spectrum of people there. So I think Barnsley 2030 for me is a platform for us to push out and kind of make this all make sense to what I describe as normal people. So in a weird way, the actual show up, whether we've got some concerns or not, but the principle of other partners across the Barnsley landscape engaging with people thinking about their health and well-being is a good example of how we use that platform. So there's just some thoughts from me, really.
So that's helpful. I think we're all trying to figure it out. Let's be honest. I talk sometimes to some people on the shop floor, you know, really, and they sometimes get a bit lost with. They do get a bit lost with actually. Well, hang on a minute. So what's that then? What's its unique? Really try to be as simple as you possibly can be about the unique space that places it without drowning them in the detail. Well, that's occupied that space, which is generally about 2030. This 2030 is a set of place leaders. Really place leaders, you know, commercial organisation, business community, commerce. It's all sorts of that leadership cohort that's settling on one or two things where if you galvanise, you know, passion and creativity across those one or two things, we can maybe go further faster. Not trying about doing anything. So that's my description usually 2030 when people ask me. I'm less clear about the health and wellbeing. I'm just being really frank. Less clear about health and wellbeing board, but I think that's what we're trying to work through that, aren't we? And figure that out. And then if we do our piece of thinking and reflection, hopefully we all come out the other end of it with greater clarity. And we put a bit of that challenge back into the ICB about all the things we've said today about, well, hang on a minute, you know, if we've got this ambition in our place arrangements to deliver 1, 2, 3, A, B, and C, these are the conditions that need to exist to enable us to deliver that, which does come back a bit to the sword. Giving us a message of investigation.
I'll go on being board. I'll text over all underlying things that we discuss here.
Yeah.
You know, like eating better and all that stuff. It's and like Bob says, it's to normal people. People who don't usually interact.
We can figure it out when you can't we?
Yeah.
Because that's the key. We can get on the table and figure this stuff out. Stop the unlimited man. Thank you for that reflection. It's really helpful. And I'm surprised I've finished part of the agenda 10 minutes early. It's a miracle every time. It's an absolute miracle. It's an absolute miracle. But then we do have to remember what we've done. So before we close the part of the meeting, let's back on with the stop the recording, please, if you would.